AIDS, Death by Prescription. By Heinrich Kremer, Stefan Lanka and Alfred Hassig. Continuum, July/August 1996. Protease inhibitors and antiviral drugs with mitochondrial toxicity, AIDS treatment with consecutive death. The advertising drums are beaten hard all over the world today. The same doctors are calling for obedient candidates for their experiments and holding out the same promise of a cure who have poisoned countless AIDS patients by administering the DNA blocker AZT for the past 10 years in an attempt to hunt down the phantom Hiv virus. The same doctors are now trying to conjure up a substance from the test tube under the magic name of protease inhibitor and to market it as having a limitless cure potential, although nobody in fact knows what long-term reactions this molecule, which has never been tested on man, may cause in the living organism. The victims and perpetrators have only recently come to realize that AZT, also known as zidovudine or retrovir, has, in countless cases, brought about the inevitable and slow asphyxiation of the patient's body cells, which are in particular need of oxygen, and hence the equally inevitable death by poisoning of those persons who are stigmatized as HIV positive or diagnosed as suffering from AIDS and who trust their doctors. Despite that realization, new test candidates are already being sought who will be voluntarily prepared, through fear of death suggested by the medical profession, not only to swallow AZT in combination with allied toxic substances, but in addition to take an inhibitor which has an incalculable impact on cell metabolism. A guarantee of success is secured in advance, as with AZT, because any fatal secondary effects of the mixture are described as an outcome of the phantom HIV infection. These are the self-same laboratory doctors and clinical practitioners who for years abused the confidence of anxious AIDS patients with the assertion that AZT would reliably, and with total certainty, prevent the proliferation of their phantom HIV. In reality, the substance AZT is absorbed by a primary route through the DNA gamma polymerase into the energy center of all body cells, the mitochondria. Without the activity of the mitochondria as former bacteria, no body cell can produce the necessary energy from oxygen and make it available for the whole cell metabolism in the bound state in adenosine triphosphate, ADP. The doctors who prescribe AZT have, however, denied this established fact and wrongly diagnosed the fatal consequences of AZT medication as the sequels of AIDS following a prior HIV infection. For example, clinical manifestations such as the wasting syndrome, HIV encephalopathy, cardiomyopathy, atrophy of the skeletal muscular system and opportunistic infections of all kinds affecting the patients are declared to be tragic consequences of AIDS. AZT manifestly also damages the mitochondria of the same microbes, protozoa and fungi, which have become adjusted to the cellular metabolism of the body in the course of evolution without being normally pathogenic. In the case of serious damage to their energy production, they may, however, undergo mutation into aggressive pathogens and may, known as opportunistic infections. The true opportunists therefore are the AIDS doctors who prescribe AZT. They have sought to drive out devils with Beelzebub. And by doing so they demonstrate their ignorance of fundamental biological processes in the human organism. But the dogmatic AIDS doctors have invented new tricks. Although, despite all the assertion to the contrary, no scientist has ever demonstrably produced a genome of the imaginary HIV which would be capable of causing infection. They announce that they have traced minute fragments of the genetic material of HIV in RNA form and enriched these fragments. Now they claim to be able to determine the precise quantity of HIV in the individual patient's blood serum. LT remains a secret of the AIDS doctors to explain how they are able to identify the part as a whole, without ever having seen the whole. By the same token, researchers could conclude from the sight of a footprint on the banks of Loch Ness that the monster of the same name really does exist. But they go on to develop a destructive logic on the basis of such arbitrary definitions. As the doctors claim on the pars pro toto principle that they can quantitatively determine the active amount of the Hiv virus in the individual stigmatized patient, they now prescribe appropriate quantities of AZT and similar toxic substances as a cocktail for the patient. A sufferer who is purported to have many fragments of the messenger substances of the genetic material of the HIV phantom in his or her blood serum, is described as an unfavorable case and receives the poison cocktail in correspondingly high doses, sooner or later the patient will be unable to escape his or her predicted fate because of the fatal toxic effects of the medication, especially as, depending on the individual patient's reaction, the poison cocktails are varied and supplemented by protease inhibitors. The purported viral load hides nothing but the measurement of particular messenger substances, RNA, in the blood plasma of selected patients. Sequences which resemble those that are defined as HIV-specific are then demonstrated. But it must be realized that such messenger substances occur in thousands of different variations, reflecting perfectly normal biochemical processes in the body, thousands of which take place simultaneously and in coordinated fashion in the metabolic interplay. Fluctuations, i.e. the increased or reduced occurrence of the sequences, are perfectly normal in this complex interplay of thousands of simultaneous metabolic processes. In the case of persons with a heightened cellular metabolism, e.g. persons under cell-destructive medication, AZT, DDI etc., and those suffering from multiple infections, these molecules may sometimes occur with a higher degree of probability, precisely because of the metabolic acceleration. The isolated presentation of measurements of a particular kind of sequence, which remains in any case totally impossible to quantify, is therefore clinically irrelevant in the absence of comparison with other molecules of this kind. There are also no comparative values which would enable any significance whatever to be attributed to these relative measurements. Proteases are in fact protein enzymes which split protein molecules into the length required in each particular case by the metabolism. They are naturally rendered inactive within and outside the body cells by special inhibiting molecules until they are recovered by complex interactions between many different molecules. The body constantly produces such protease inhibitors, e.g. heparin, and the heparinoids. The HIV hunters now claim to have produced protease inhibitors in the test tube which will specifically only inhibit those proteases that are said to be responsible for the proliferation of the hypothetical HIV. They want to measure the success of these protease inhibitors by a quantified reduction of the arbitrarily defined viral load, see above, and the relative increase of the T helper cells. In other words, one fiction, virus blocking, is legitimated by another, virus cell quantification. The temporary increase of T helper cells is brought about by the partial displacement of cells of this type from the bone marrow and other compartments into the bloodstream through temporary inhibition of the catabolic metabolism, which predominates in HIV-positive patients. However, in reality it is to be feared that sooner or later the unphysiological intervention in the complex interplay of body cell growth factors through artificial protease inhibitors will disturb equally vital functions of the basic tissue and cells, together with their mitochondrial energy centers, as is already the case when AZT and allied nucleoside analogues are administered. However, as no animal model is available for preliminary clinical testing, the HIV-positive patients and AIDS sufferers who go in fear of death must put their life on the line. Every test subject should therefore be aware that treatment with cocktails of AZT and allied toxic substances plus protease inhibitors may be equivalent to joining a suicide squad with a time fuse. Finally, attention is drawn to the healthy organism where proteases and antiproteases are in equilibrium. Heparinoids at the cell surface are the normal antiproteases. An imbalance can be corrected by oral administration of heparinoids in the form of extracts of cartilage, chondroitin sulfate, and agar extracted from seaweeds. We suggest that anti-HIV positive individuals take advantage of this simple and cheap possibility to correct a possible deficiency of antiproteases. Acquired iatrogenic death syndrome, AIDS. Pneumonias and lung diseases. By Heinrich Kremer. Continuum November/December 1996. PCP accounts for the majority of Western AIDS diagnoses, yet the diagnosis of AIDS can be given on the basis of a presumptive diagnosis of PCP alone. A positive HIV antibody test is not even necessary. Is this definition alone creating a hothouse of fear and, with its assumptions, distracting patients and doctors from recognizing the real processes of risk? In particular, the revelation that PCP is not an opportunistic infection challenges itself the wisdom of drug prophylaxis. In 1996, the respected British medical journal The Lancet began publishing a series of special articles about HIV and AIDS, addressing various aspects from vaccines to the nervous system. All the articles rashly assumed that an isolated retrovirus called HIV causes AIDS. In the following article, Dr. Heinrich Kremer responds to one such article, by Dr. Miller, on HIV-associated respiratory diseases. In a knowledgeable and inquisitive manner he brings into unrelenting focus the deeply disturbing way in which damaging medication has helped create rather than cure the problems of PCP and other conditions. Pneumonia is a frightening prospect for anyone, treating physicians included. Undoubtedly prevention is better than cure. But does this involve a fresh commitment to look behind the plague-mongering to the sensitivity of our biological systems, and the pressures of present and cumulative chemotoxicity? Progress comes from individual creation and imagination, not from the narrow dogmatism of a burgeoning AIDS establishment. The Lancet editorial, July 6, 1996. It was one of the early pioneers of modern medicine, the German physician Rudolf Virchow, 1821–1902, who, at the height of his career, said he wanted to become an MP in order to see to the completion of Berlin's antiquated sewage system, otherwise he could not successfully fight tuberculosis. How right he was! Only 100 years ago 1 worker in 3 died of tuberculosis. But until about 1950 tuberculosis had become rare in Western industrial countries, practically without recourse to drugs, which only became available towards the end of the 1940s. Above all, improvements in hygiene, living conditions, and nutrition were instrumental in curbing tuberculosis of the lung. Nowadays, however, there are modern successors to Virchow's causes of tuberculosis to surprise us, namely, the association between HIV infection and tuberculosis is well described. Tuberculosis in an HIV-infected individual is an AIDS-defining illness. This claim is one of the many assertions by Dr. Miller in his article HIV-associated respiratory diseases, which he divides into 8 infectious and 4 non-infectious diseases. Infectious: 1. Upper respiratory tract infections, 2. Acute bronchitis, 3. Acute sinusitis, 4. Bacterial pneumonia, 5. Pneumocystis carinii pneumonia, 6. Mycobacterium tuberculosis, 7. Mycobacterium avium intracellulare, 8. Fungal pneumonia, non-infectious, 1. Kaposi's sarcoma, 2. Lymphoma, 3. Non-specific. Interstitial pneumonitis, 4. Lymphoid interstitial pneumonitis. Now, it turns out to be something of an advantage for me as a medical doctor to have kept away from conferences and not to have much beyond schoolboy English, because I had to check up on the exact meaning of association and associated in the Oxford Dictionary, to find that they mean connection in the mind. In other words, we are dealing with a suggested mental, rather than causal, connection between HIV and respiratory disease, as well as between HIV and tuberculosis. Does Dr. Miller want to lecture us on ideology rather than biology? Not at all, Dr. Miller quickly explains. Tuberculosis is a potent stimulator of cell-mediated immunity, activating HIV production in lymphocytes and monocytes/macrophages latently infected with HIV, which brings out the spread of HIV infection to other cells. It dawns on me why tuberculosis -1.7 billion infected worldwide, 600 million cases annually, 2 million deaths, of which 95% are in developing countries. In Western countries less than 0.05% of the population is affected by the disease, of which more than 95% are homeless, alcoholics, for drug users, asylum seekers, is an AIDS-defining illness. Up till now AIDS-defining illnesses were supposed to be the consequence of alleged causative HIV infection. It now seems that diseases which first have to rouse dormant HIV from CD4 lymphocytes and macrophages are also part of the AIDS collection. This means every disease process which has in any way reacted with thymus-matured immune cells, T cells, can henceforth be renamed an AIDS-defining disease, if it can simultaneously be associated with HIV. There are no limits, therefore, to what can be done in the virtual, toy-town world of AIDS, since in practically all serious diseases there is some contribution of cell-mediated immunity. Dr. Miller grabs this opportunity by the throat and lists all 11 associated respiratory diseases, and observes that the clinical features of upper respiratory tract infections, acute bronchitis, and acute sinusitis are the same in HIV-infected individuals as in those without HIV, but their frequency is increased. So saying, Dr. Miller has deftly dealt with 3 of his 8 infectious HIV-associated respiratory diseases. Bacterial pneumonias. But it gets more serious when Dr. Miller classifies as the 4th HIV-associated disease group bacterial pneumonia. The spectrum of bacterial pathogens is similar to that of community-acquired pneumonia in the non-HIV-infected population. In this disease group, too, Dr. Miller offers an intellectual prop to the HIV Association. Bacterial pneumonia occurs more frequently in HIV-infected individuals than in the general population and is especially common in HIV-infected intravenous drug users. Indeed, in the general population in Germany, for example, less than 1% of the population is affected by bacterial pneumonias. 4 drug users suffered more frequently from bacterial pneumonias long before AIDS came along for reasons well known to the venerable Fierco: unsatisfactory hygiene, malnutrition, bad housing, etc., etc., see above. The really important point, however, Dr. Miller conceals from us: 4 drug users classified as HIV-infected suffered from bacterial pneumonias, as a comprehensive study in Berlin has shown, whereas non-bacterial pneumocystis carinii pneumonia, PCP, the most frequent HIV-associated respiratory disease in Miller's list, and the most frequent HIV-associated disease or AIDS-defining illness altogether in the West, does not to all intents and purposes feature at all in 4 drug users who are not homosexual. We can now see more clearly why bacterial pneumonias that are on the official list of AIDS indicator diseases in adults only if they occur more than twice a year, have to be wangled in under the guise of HIV-associated. Without the creation of HIV, no one would ever have dreamt of the need to diagnose 4 drug users as AIDS, because PCP and Kaposi's sarcoma, the most common AIDS indicator diseases, do not occur in non-homosexual 4 drug users in Western countries despite a laboratory finding of HIV positive. Why does Dr. Miller conceal these facts in his Lancet article? Dr. Miller lumps together everything which in patients labeled HIV positive could be called respiratory tract diseases. Because the introduction of a new cause for these long-known diseases from the same long-known causes, in the very same long-known categories of persons, would seem rather untrustworthy, he makes these old-timers among the common respiratory tract diseases the driving force of the newly invented HIV infection and lumps them together as HIV-associated disease or AIDS-related processes as he likes to call them. That these patients are thereby exposed to an increasing number of pharmaceutical drugs does not seem to worry Dr. Miller unduly, as his treatment of PCP, the 5th of the 8 HIV-associated diseases in his list shows. Pneumocystis carinii pneumonia. Strangely, pneumocystis carinii pneumonia turns up here as a genuine AIDS indicator disease under the conditional heading of HIV-associated respiratory disease. Has Dr. Miller lost faith in the orthodox belief in AIDS? Not at all. He quickly goes on to explain. P. carinii remains a common respiratory pathogen in individuals with AIDS. Miller again uses the idiosyncratic phrase in individuals with AIDS. A doctor's diagnosis of PCP alone is entirely sufficient according to the most official AIDS definition to say this patient is an AIDS case or this patient has AIDS. And this attribution of AIDS due to the diagnosis of PCP alone, establishes 40% of all clinical AIDS cases and about 80% of all AIDS deaths in Western countries. The official definition of the authoritative American CDC has since 1987 remained unchanged. An AIDS diagnosis is justified even if only a presumptive diagnosis of PCP exists, and in the absence of any laboratory suggestion of HIV positivity, and without any noticeable decline of immune cell values in blood serum. Thus, PCP was from the beginning synonymous with AIDS, even without the S, for syndrome, of another 28 diseases, and without the ID, for immune deficiency, interpreted from decrease in CD4 lymphocytes in the bloodstream, and without the A, for acquired HIV infection. Naked PCP therefore is the seed of AIDS. Everything else Dr. Miller and his colleagues associated as connections in the mind. In plain language, if there are other good reasons for the occurrence of PCP in homosexual patients, the HIV-associated diseases just melt away as yesterday's snow. In this respect, Dr. Miller comes up with a genuine surprise. Miller explains in considerable detail that according to the latest research findings, the pathogen responsible for PCP is an airborne fungus and not, as thought up till now by AIDS doctors, a unicellular animal parasite. This implies an enormous difference from the diagnostic and therapeutic point of view, and in the real case of an individual patient, this reclassification can mean the difference between forecasting life and death. Until now, epidemiologists assumed PCP was a case of zoonosis, i.e., a ubiquitous animal, prevented by cell-mediated immunity from breaking through the body's immune barrier and causing devastating pneumonias. This assumption was seemingly based, according to Dr. Miller, on the finding that 90% of children and adults in Western countries had antibodies to P. carinae without contracting that form of pneumonia. But now it turns out the essential assumption, that the presence of antibodies indicates the presence of the pathogen, was fundamentally mistaken. P. carinae cannot be detected with DNA amplification or monoclonal antibodies in bronchoalveolar ravage fluid or necropsy lung tissue of immunocompetent individuals, and low levels of P. carinae are detected in the lungs of only 20% of immunosuppressed HIV-positive patients with respiratory episodes and diagnoses other than P. carinae pneumonia. The conclusion is, therefore, that HIV was invented in order to explain the apparent fact that CD4 lymphocytes in ostensibly hitherto healthy individuals could suddenly no longer hold in check the pneumocystis protozoa which had been there all along. The simple explanation which the now shattered HIV/AIDS theory led to, was, HIV is transmitted in semen, blood, and blood products to the recipient. HIV destroys the thymus-matured CD4 lymphocytes. The pneumocystis protozoa escaped their dead guards and kill their up till then healthy host. HIV was invented in order to explain the apparent fact that CD4 lymphocytes in ostensibly hitherto healthy individuals could suddenly no longer hold in check the pneumocystis protozoa which had been there all along. According to this nightmare scenario, anyone with HIV in his CD4 cells dies. But suddenly now, everything turns out to be completely different. Pneumocystis protozoa cannot escape from the CD4 immune cells, because pneumocystis protozoa are not there. Instead, since P. carinae is a fungus, is not transmitted in semen or blood, and is passed on through the air. This fungus, as Miller informs us, can be disposed of easily in 80% of immune-suppressed HIV-positive patients with respiratory episodes and diagnoses other than P. carinae pneumonia, without leaving a trace, and leaving in the rest of these immune-suppressed HIV-positive patients just low levels of P. carinae, whatever that may mean. So, what has the laboratory finding of HIV-positive got to do with P. carinae pneumonia? What conclusions does Miller draw from his newly discovered findings? Answer: none. Miller simply reports the fact and carries on treating his patients as before. The regimen of first choice for primary and secondary prophylaxis of P. carinae pneumonia is CO-trimoxazole, 960 mg once a day or 3 times a week. For treatment, first choice is high-dose CO-trimoxazole, 100 mg/kg per day of sulfamethoxazole and 20 mg/kg per day of trimethoprim, in 2 or 4 divided doses, orally or intravenously, for 21 days. The important point arises: how does the metabolism of a unicellular animal, protozoan, which normally just vegetates as a harmless opportunist in the undamaged environment of a lung, differ from the metabolism of a unicellular fungus, an external recycling specialist, which, even in immune-suppressed patients, apparently thrives only when suitable growth conditions are present in the lung? Miller, unsurprisingly, is silent on that question. Another question is who or what is responsible for the substrate, the suitable growth conditions, for P. carinae in the lung? HIV? The patient? Or his treating doctors? The imaginary retrovirus HIV or a shortage of CD4 cells, allegedly massacred by HIV, cannot be decisive for creating the special environment in the lung which enables P. carinae to multiply freely. Miller himself observes that many immunosuppressed HIV-positive patients do not have in the lung any P. carinae or show only traces of it. The question arises, therefore, whether cell-mediated immune deficiency, the laboratory finding of HIV-positive, and the production of the substrate for P. carinae could not all be traced back to a systemic change in the body's metabolism. Miller provides an important clue by mentioning that administration of corticosteroids to rats can provoke PCP. Experiments of this kind date back to the 1950s, which Miller does not mention, after what was later called PCP was first recognized in the 1930s in premature babies. Similar symptoms of atypical non-bacterial pneumonia, as opposed to typical bacterial pneumonia, were diagnosed in the 1940s in children and adults in famine conditions. So, what do the steroid-treated rats, the premature babies and the starving children after the Second World War have in common? Note, PCP was at the time practically unknown in the United States. The premature babies hardly stood a chance before modern treatments came along. They suffered from their immature lung cells a highly acute oxidative stress which in turn led to massive hypercortisolism. They mostly died from bacterial infections. These could be controlled more successfully after the introduction of the first broad-spectrum sulfonamide, Prontosil, at the end of the 1930s. But then they died instead from PCP. Although the sulfonamide, which is a folic acid antagonist, i.e. prevents the building of folic acid, successfully halted the production of bacterial proteins and hence bacterial reproduction itself, at the same time they raised the catabolic stress. See footnote. Because the necessary maturation of CD4 lymphocytes, T cells, in the thymus gland is very susceptible to hypercortisolism and systemic oxidative stress, the task of T lymphocytes to dispose of the extremely increased turnover of cells became practically impossible, and the resulting decomposition products of the catabolic metabolism, especially in the lungs which are particularly susceptible to oxidative stress, built the special conditions for the ubiquitous airborne spores of P. carinae to thrive in. These rather complex PA/HO physiological processes, unknown about, of course, in the 1930s, would also explain the PCP seen in rats which had been treated with corticosteroids while under antibiotic treatment. Hypercortisolism induces a characteristic famine metabolism which leads to complicated systemic changes in growth and decay of the body at the molecular level, and provides the substrate for the highly specialized pneumocystis fungi to grow on. If this vital emergency condition, under constant stress factors, becomes a fixed lasting condition, as in the starving children of post-war Europe or in parts of Africa today, thymus-dependent cells, T cells, decrease. In the normal course of events, these T cells have to get rid of 1012 spent body cells a day. By halting the maturation of T cells, the table becomes richly set for P. carinae and other microbes to thrive. These unwelcome scroungers can only be chased away from this paradise of theirs, by abolishing the fixed emergency conditions that created it. This explanation is confirmed by the animal experiments quoted by Dr. Miller. 75% of P. carinae were found to have been disposed of within 1 year of ending the artificially induced hypercortisolism. So, what could Dr. Miller have learned from this brief glance into the history of PCP to benefit his patients, ostensibly stricken with HIV-associated respiratory diseases? First, that PCP and the fungal pneumonias could thrive very happily before AIDS came along, and long before any hypothesized retrovirus, which is not supposed to have existed before 1978, could have been involved, under the systemic environmental changes in the lung due to excessive situations of oxidative stress under a persistent catabolic level of metabolism. Secondly, Dr. Miller could have learned that the common factor between the phenomena called CD4 cell immunodeficiency, P. carinae growth conditions, and the laboratory finding of HIV positive can be found in the fact of excessive forced oxidative stress. The construction rules of the anti-HIV antibody test lead also to this conclusion. Dr. Gallo and his colleagues brewed their test soup from already overstimulated CD4 lymphocytes obtained mainly from the serum of PCP patients as well as from cells of a particularly division-prone leukemia cell line, spiced this with powerful oxidizing agents, called mitogens, added a generous dash of hydrocortisone, and incubated it thoroughly. They then fished out of this brew a mixture of proteins which they ascribed to a hypothetical retrovirus, HIV. It follows that these proteins, antigens, released under the oxidative stress in the test tube, will necessarily bind to their complementary proteins, antibodies, from the serum of patients who had themselves, due to pathophysiological processes, formed proteins analogous to the test antigens from GALLO's brew. Antibodies found in HIV positives are therefore to be seen as nothing other than increased levels of autoantibodies against endogenous proteins which have been produced as a result of highly increased cell turnover under chronic oxidative stress. Thirdly, Dr. Miller could have learned from all these findings that these laboratory artifacts known as HIV positives represent anything but the presence of a transmissible mass epidemic due to semen and blood. The annual incidence of the false diagnosis HIV-associated diseases for the whole population of Germany is 0.002%. This result contradicts eloquently the absurd apocalyptic predictions of AIDS doctors. The official annual rate of new infections in the general population in Germany of the clinical misdiagnosis HIV-associated P-carinae pneumonia is practically 0.00%. And among gays amounts to just about 0.05%. This true rate, differing starkly from the predicted rate, is well within the range of other epidemiological burdens of other population groups, e.a. the annual incidence of lung cancer in all smokers is 0.1%. On the other hand, the annual rate of miscarriages due to folic acid shortage in mothers is also around 0.1%. And is strikingly close to the incidence of folic acid inhibition following medication with CO-trimoxazole, of which more below. Medical treatment. Perhaps the most important lesson for survival of those affected is the question, what is the effect of the medical treatment on the development and course of HIV-associated P-carinae pneumonia? Dr. Miller is quite revealing in two respects of this without seemingly being aware of the consequences this entails. First, he is perplexed. Despite the widespread introduction of effective primary and secondary prophylaxis, P-carinae pneumonia remains a common respiratory pathogen in individuals with AIDS and continues to account for almost half of all respiratory episodes. Without in any way justifying the alleged efficacy of his primary and secondary prophylaxis, he defines his preferred mixture of CO-trimoxazole with seemingly precise milligram amounts as a multipurpose weapon prophylaxis against prokaryotic and eukaryotic unicellular life forms in three domains of life at the same time, against fungi, including P-carinae pneumonia, protozoa, including Toxoplasmosis gondii, and bacterial infections. The regimen of first choice for primary and secondary prophylaxis of P-carinae pneumonia is CO-trimoxazole 960 mg once a day or 3 times a week. This may also afford some protection against bacterial infections and against reactivation of cerebral toxoplasmosis. The curious reader also gets to learn from Dr. Miller, 15 years after being first reported by the CDC, June 1981, about the failure of treating homosexuals with CO-trimoxazole who had PCP, 2 out of 5 died, but nothing of the mechanism of this chemotherapeutic agent, often wrongly prescribed as an antibiotic. CO-trimoxazole, better known under its trade names Bactrim and Septrin, contains a combination of sulfamethoxazole, a sulfonamide, and trimethoprim, a cytostatic agent which is also used to treat leukemia in the same form, i.e. to destroy white blood cells. Sulfamethoxazole inhibits the synthesis of folic acid which is essential to life, by substituting the paraminobenzene, PABA, moiety, so that the enzyme responsible for folic acid synthesis is consequently blocked. Trimethoprim inhibits conversion of folic acid into the biologically active form of tetrahydrofolate by blocking the enzyme dihydrofolate reductase. Without tetrahydrofolate, essential precursors for new DNA cannot be synthesized. For example, the nucleoside uridine has to be methylated by methylene tetrahydrofolate to form the essential DNA building block, thymidine triphosphate, TTP. This is the same component that is displaced with the notorious cell poison, azidothymidine, better known as AZT, zidovudine, or retrovir. CO-trimaxazole, therefore, works in a different way, but with a similar result to AZT, as a DNA blocker. The consequences of inhibiting essential metabolic pathways for growth, cell differentiation, and division are fatal. The synthesis of essential nucleic acids, proteins, and enzymes develops faultily, or ends completely. Cell damage. This treatment with combined trimethoprim/sulfamethoxazole equals CO-trimoxazole is especially serious for the functioning and fine structure of mitochondria in nucleated, eukaryotic, unicellular and multicellular species, protozoa, fungi, plants, animals, humans. Mitochondria, so-called organelles, are the major suppliers of energy in human cells, except in red blood cells. They are endosymbionts, former bacteria with a double membrane. They contain remnants of their ancestral genome. This mitochondrial DNA, mtDNA, is irreplaceable in the synthesis of protein subcomponents of the respiratory chain. For respiration, activated electrons in the respiratory chain from nutrients using oxygen are built into the universal energy source for the entire cell, adenosine triphosphate, ADP. If the synthesis of precursors of DNA is harmed through chronic or high-dose treatment with CO-trimoxazole, the mitochondrial DNA is damaged and altered, which in consequence impairs mitochondrial proteins, as well as the proteins of the respiratory chain, and ADP production therefore decreases. This leads to increased oxidative stress and to an increase in toxic oxygen-free radicals. A vicious circle is set up once the ADP levels reach a critical low, and if the special molecules which normally remove harmful oxygen intermediaries are all used up, then further DNA damage arises. The cell initiates programmed cell death, because the ion pumps which regulate the balance of the flow of manifold molecules of building supplies and working materials into and out of the cell necessary to maintain cell function, fail for lack of fuel in the form of ADP. Incidentally, DNA blockers such as CO-trimoxazole and AZT, fundamentally damage predominantly the mitochondrial DNA, because the mitochondria cannot repair any mismatches or breaks in their DNA, unlike the much longer and specially protected double-stranded DNA in the cell nucleus, which can. DNA in the nucleus is passed on by sexual reproduction and is recombined, whereas mitochondrial DNA is propagated asexually through the maternal egg cell, which means that mutation errors are not corrected but conserved. The mutation rate of mitochondrial DNA is 5 to 10 times higher than for nuclear DNA. The nuclear DNA, being surrounded by its own membrane, is physically better shielded, as well as benefiting from protective proteins and enzymes from any damaging effects of the metabolism than is mitochondrial DNA, which in bacteria is scattered loose throughout the cell plasma, and in several copies. The above basic facts of cell biology apply, of course, with greatest force in rapidly maturing cells with short half-lives, especially the thymus-matured lymphocytes, T cells, whose job is not only to recognize and, with the help of other immune cells, eliminate foreign proteins, but also to remove altered self-proteins without causing inflammation. If this cannot be done adequately because of infectious, toxic, nutritional, psychological, or other overload, the body enters a state of emergency. The B-cell system is stimulated to produce antibodies and autoantibodies as well as macrophages and many inflammatory mediators, and the entire metabolism is transformed. Over the short term, the body can deal with such a state of emergency. If this state persists, however, a chronic maturation deficit of T lymphocytes, T helper cell deficiency, arises, and the now permanently changed environment becomes the feeding ground, substrate, for the recycling activity of fungal parasites. In Greek, parasite means unwelcome scrounger, and as a consequence of B-cell activation, specific autoantibody profiles make the anti-HIV antibody test turn positive, just as in some autoimmune diseases such as rheumatoid arthritis and lupus. Erythematosus. Under these conditions of highly acute state of emergency such as is found in immune-suppressed patients, it does not require the wisdom of Solomon to see that the treatment methods of Dr. Miller and his colleagues will induce precisely that which they seek to avoid, namely, an acquired immune deficiency syndrome, AIDS, induced through wrong medical practice. Why does Miller apparently not know anything of the special vulnerability of mitochondria to CO-trimaxazole? Does he not know that in wanting to stop fungi, protozoa, and bacteria prophylactically, he simultaneously attacks the driving force of all body cells, the mitochondria, as well, since they are former bacteria themselves? Dr. Miller comments truthfully. As many as 25% of patients receiving prophylactic CO-triamoxazole develop adverse drug reactions. 50% of patients receiving treatment doses likewise develop adverse reactions. But Dr. Miller describes only the massive side effects of short-term therapy, though he appears to be genuinely surprised by their intensity in HIV-associated diseases. There is no clear explanation for such a pronounced increase in adverse reactions to CO-triamoxazole, which is about 20% greater than seen in the general population. It is a pity that he does not give some thought to the long-term use in prophylaxis of folic acid inhibitors like CO-triamoxazole, let alone in combination with AZT, zidovudine, DDC, zalcitabine, DDI, didanosine, D4T, stavudine, 3TC, 2-deoxy-3-thiacididine, the newer protease inhibitors, sequinavir, ritonavir, indinavir, neltanavir, or the newest non-nucleoside reverse transcriptase inhibitors, delavidine, nevirapine, and others. Are not the long-term damaging effects of using combined folic acid inhibitors really the major cause and not the consequence of what Dr. Miller and colleagues perceive to be HIV-associated disease? Drug history. CO-triamoxazole was brought into clinical use in the early 1970s, i.e., more than 20 years ago. Individually, sulfamethoxazole and trimethoprim inhibited the growth of pathogens only, whereas both together as CO-triamoxazole killed off a wide range of microbes. This was of great significance in the treatment of multiple infections of a minority of homosexuals in the large Western metropoles. The purpose of treatment in most cases was simply to suppress as quickly as possible the wide spectrum of microbial growth encountered. CO-triamoxazole quickly became the wonder drug with specialist doctors and their homosexual patients in Western metropoles. This double-action folic acid inhibitor was used not only to treat but to forestall, incredibly, often by self-administration, unthinkingly, in exactly the same way as nowadays Dr. Miller and his colleagues do, too. Moreover, in far too high doses and for far too long a time, especially against the often refractory urinary tract and intestinal infections, and atypical pneumonias in this group of patients. A literature search since 1970 does not come up with a single publication about the side effects of CO-triamoxazole on the functioning and fine structure of mitochondria, nor on the connection between T-cell deficiency itself and CO-triamoxazole. Yet there has always been ample evidence in the literature for the damage caused to all white blood cells, including lymphocytes, in various groups of patients, even during short-term use of CO-triamoxazole. The only investigation of up to 45 days after beginning treatment with CO-triamoxazole was conducted in Britain by the General Practice Research Group in 1988-93. Since folic acid reserves in man can last up to 4 to 5 months, significant damage to patients with HIV-associated infectious diseases often manifests itself only after long-term prophylactic use exceeding 8 weeks, which is then interpreted as AIDS symptoms. Surprisingly, until the appearance of AIDS in 1981 there were no reports in the medical or pharmaceutical press about the damaging effects of CO-triamoxazole use amongst homosexuals, although the side effects in this group should have stood out like a sore thumb, because of the high dosages and duration of treatment. The matter was obviously declared a taboo subject until P. carinii fungi as a recycling agent began to run amok in the lungs of these patients, sometimes after they could not be controlled even with high doses of CO-triamoxazole, as was first reported by the CDC as long ago as June 1981. Instead of at least by then asking themselves what the damaging consequences of chemotherapy in this group might be, all those concerned indulged in a fit of collective mental repression regarding the interpretation of the symptoms they were witnessing, which later on became rationalized as a new lethal syndrome due to a new pathogen. Egged on by a prurient media relishing plague fantasies, the medical establishment transformed a set of new and old symptoms into an apparently uniform disease process using the codes AIDS-related processes and HIV-associated diseases, which supposedly resulted as a wide chain reaction of the primary effect, a virus invasion, which anyone could catch through sex and blood. This interpretation had the tremendous advantage over more mundane explanations that neither the doctor nor the patient had to question their own role in the dynamic of the case history. The new syndrome started, so to speak, ahistorically. The pharmaceutical industry could exploit the ensuing fear of death with impunity, instead of initiating a fundamental reappraisal of unphysiological chemotherapy and treatment, involving the testing and use of ever more powerful combinations of highly toxic mixtures on a global scale, financed by all of us, in a seemingly heroic battle against a plague threatening humankind. The world's largest manufacturer of CO-trimoxazole has meanwhile confirmed in writing that there have never been any investigations into the effect of folic acid antagonists on mitochondrial integrity. Strangely enough though, the indications, recommended circumstances under which to prescribe a drug, at least in Britain and America for CO-trimoxazole, have been severely reduced, because of frequent side effects during short-term use, CFBNF, FDA guidelines. Excepted from this change, special indications of prophylactic and therapeutic high doses and long-term use and infrequent intermittent therapy, itself a long-term use because of cumulative damage, were expressly permitted for HIV-infected patients and PWAs. In this light, the concerned statement of Dr. Miller. Despite the widespread introduction of effective primary and secondary prophylaxis, Bacterial pneumonia remains a common respiratory pathogen in individuals with AIDS. Becomes a self-fulfilling prophecy. In the early 1980s, the use of CO-trimoxazole had reached the very high annual incidence of 5% of the population, about equal to that of alcoholism, while use of CO-trimoxazole by homosexuals in Western countries, the taboo subject, in particular in metropoles and in the neighborhoods of specialized practices and clinics, must have likely been, and continue to be, considerably higher. It was recommended to restrict the general indication of the drug, because of the high level of damage to blood cells, including lymphocytes, while, gruesome to relate, the prophylactic and therapeutic indication for already immune-suppressed patients, stigmatized as HIV-infected and PWAs, were relaxed. If the number of CD4 cells necessarily declines because of DNA blockage and mitochondrial damage through CO-trimoxazole, because of increased cell death and inhibition of maturation, then AIDS will be diagnosed, and the range of DNA blockers and mitochondria killers constantly enlarged. The blind zeal of virus hunters leads them to use ever more frantic chemistry without, as Dr. Miller shows, ever stopping to think about the vital basic conditions of the intertwined biospheres of our bodies. The patient will go through all the stages of AIDS described in textbooks, and at the end of it, all the participants will feel bitter at having lost the battle, at great sacrifice against a fickle enemy. Despite calling on all means available, the patient will have dutifully suffered a ritual death for the sake of a plague-hungry society. The frustration of the doctors and their companions in death will have been transformed into aggression against those who have insisted all along on a genuine re-evaluation of their actions. Pre-existing immune deficiency. If the premise of an inexplicable immune deficiency affecting hitherto completely healthy individuals had turned out to be true, then the virus AIDS theory could have been a reasonable working hypothesis. But because AIDS, according to the official CDC explanation, is supposed to be a serious disease of acquired immune deficiency without pre-existing or induced immune deficiency, it has to be stated quite unequivocally that such AIDS cases have never been found up till now, except in the form of a medical mantra of plague propaganda, because in all verifiable cases, demonstrable immune suppressive disease and/or treatment have always preceded them. There has never been a need, therefore, to explain an inexplicable immune deficiency, because the causes were there for all to see. And a new virus was entirely redundant for an understanding of the disease process, irrespective of whether the suggested retrovirus HIV existed or not. For example, the annual incidence in Germany of AIDS in the population as a whole is just 0.002%, and amongst homosexuals 0.1%. Intriguingly, more than 60% of all AIDS cases in a population of 80 million occur in the immediate vicinity of 6 large university clinics in 6 towns, which rather supports the view that AIDS should be called an acquired iatrogenic death syndrome. Furthermore, according to Dr. Jaeger, in a live interview, one of the leading German AIDS authorities, president of the Curatorium for Immunodeficiency, Munich, in the period from the ostensible beginning in 1981 to 1996, there has not been a single case of male or female HIV infection in the age group 14 to 20, not even in homosexuals, although every school kid has had the exact opposite drummed into him, which is proof that the advocates of HIV/AIDS are by now unwilling to separate fact from fiction, even for the sake of the patients entrusted to their care. Plague mania. Dr. Miller really should have another look at Virchow's writings in order to understand why TB had practically lost all its horrors in Western Europe without use of chemotherapy, and why now, in his own words, multiple drug-resistant, MDR, tuberculosis has emerged as an important clinical problem in HIV-infected patients in the USA. Dr. Miller fails to mention, however, that chemotherapy for Mycobacterium tuberculosis and Mycobacterium avium intracellulare, NOS 6 and 7 in his list of HIV-associated infectious diseases, also require high levels of folic acid, thereby inducing a relative shortage of folic acid, ideal conditions for DNA mutation to occur. In Africa, by the way, in a different mycobacterial disease, leprosy, the anti-HIV antibody test reacts positive as well. Because African AIDS, apparently 90% of all AIDS cases worldwide, is as a rule nothing other than old well-known clinical conditions such as TB, malaria, hepatitis, diseases caused by worms and slim, all the result of poverty, hunger, and inadequate hygiene, in the sense that Virchow meant, they're the HIV-associated respiratory tuberculosis in Dr. Miller's terminology, turns out to be just plague-mongering. As Dr. Miller rightly says, TB is a potent stimulator of cell-mediated immunity. But he doesn't say that if the store of immunity is constantly being used up, and, for all the reasons explained above, not properly replenished, then a deficit does indeed arise, resulting in an acquired immune deficiency syndrome. However, even in such cases, immune-suppressive disease and/or treatment have preceded the appearance of the syndrome. It is not a case of independent AIDS in the CDC sense, which requires an explanation based on HIV association. The HIV association is, as far as this elementary disease process is concerned, exactly the reverse: a life-threatening connection in the mind which has led to a collective plague mania, which has completely lost sight of the true causes of disease. Anniversary. It might be appropriate to mention that the German medical profession these days is commemorating the 50th anniversary of the Nuremberg doctors' trials, during which doctors stood accused of crimes committed under the Nazis. Amongst other things, one can see in the transcripts that experiments were performed on concentration camp inmates, including homosexuals, using sulfonamides to treat infectious diseases that had been induced specially for this purpose. Sulfonamides were used knowingly to cause death in innocent victims. Nowadays the chemical cudgel of sulfonamide plus trimethoprim, equals CO-trimoxazole, plus AZT, etc., is hurled about, of course, only with best intentions and not to be compared with the crimes of doctors in Nazi times. The lethal effect of AZT on mitochondria has by now been amply proved. An analogous effect of long-term use of CO-trimoxazole is equally plausible. Does it not occur to anyone, bearing the Nuremberg trials in mind, that it is high time to discuss the ethical consequences of the virtual medicine currently practiced, which under the presence of an imagined globe epidemic, force-feeds highly toxic drug cocktails to terrorized patients, on the basis of a laboratory artifact? What Dr. Miller and colleagues clearly find hardest to do, is to question their own doing. Anyone who uses CO-trimoxazole, AZT, etc., which we know very well induce immune deficiency in the long run, to combat immune deficiency, is put in the same position as someone in the 19th century prescribing bloodletting to treat anemia, knowing full well that millions perished as a result of that treatment. Just 10 days use of CO-trimoxazole can, as has been observed in some instances, result in anemia. Nonetheless, Dr. Miller and colleagues continue to advocate CO-trimoxazole as the prophylactic treatment of first choice, until the patient dies. Since the life-threatening consequences of this long-term iatrogenic intoxication with CO-trimoxazole, in complete analogy to the no longer to be denied consequences of long-term AZT use, are not ascribed anymore to the CO-trimoxazole treatment itself, alone or in combination with AZT, but are misinterpreted as the predicted HIV-associated infectious diseases and AIDS-related processes. Dr. Miller arrives at the unbelievable breathtaking conclusion. In patients with adverse reactions, desensitization to CO-trimoxazole is successful in as many as 80% of cases. What Dr. Miller does not say is that mortality due to PCP, as a fraction of the total number of AIDS deaths in the Western world is despite, or because of, medication with CO-trimoxazole also 80%. Heinrich Kremer MD was medical director of the Federal Clinics for Juvenile and Young Adult Drug Offenders for 5 German counties, including Berlin, Bremen, and Hamburg. Special thanks to HA Christi and Continuum staff, Volker Gildemeister and Stefan Lanka for their support of this work. 15 years of AIDS. The continuous failure in the prevention and treatment of AIDS is rooted in the misinterpretation of an inflammatory autoimmune process as a lethal, viral venereal disease. By A. Hassig, H. Kremer, S. Lanka, W. X. Liang, K. Stamfli. May 1998. Summary: the question of the specificity of the anti-HIV antibody test has to be re-evaluated, as it was shown that the viral enrichment obtained from CO cultivations of patients' lymphocytes with fetal cord blood by Bacterial Pneumonia and leukemia cells by GALLO ETAL, exclusively consisted of proteins of the cell types used in the cell culture. This precludes a clear separation of presumed retroviral and cellular proteins or extracellular matrix proteins. In this context, it was shown that the anti-HIV antibody test detects autoimmune antibodies directed against cytoskeletal proteins, e.g. the liver cells. Strongly augmented anti-actin autoantibodies is considered close to pathognomonic for chronically active hepatitis. The original assumption that reverse transcription from RNA to DNA is evidence for the existence of retroviruses was wrong. In fact, reverse transcription is a vital mechanism for the maintenance of the genome. The decrease in numbers of circulating CD4 lymphocytes can be explained by a stress-induced hypercortisolism. Up to date, direct HIV-mediated destruction of CD4 lymphocytes could not be proved. The same is true for measuring of the viral load. Shortcomings of the applied method to quantify the viral load do not permit definitive conclusions. Possibly, it may be taken as an expression of a stress-induced weakening of the cellular immune reactions, in the course of which the nucleoside fragments resulting from the current cell turnover are inadequately eliminated. Furthermore, the treatment of patients with nucleoside analogues has a toxic effect on both the genome of the cell nucleus and the mitochondria. The latter, therefore, may produce insufficient amounts of ADP, causing organ failure and, eventually, death. The synthetic protease inhibitors used these days are associated with serious side effects. Therefore, it seems worthwhile, in these patients, to bring back the catabolic situation due to whole body inflammation to homeostasis by administering anabolic phytopolyphenolic compounds. AIDS is the abbreviation for Acquired Immunodeficiency Syndrome. AIDS, as a term for an illness, originated in the search by the American Centers of Disease Control for sick homosexual men, also suffering from Kaposi's sarcoma, KS, and/or pneumocystis carinii pneumonia, PCP. In 1983, Bacterial et al. Reported on a T lymphotropic retrovirus which they allegedly isolated from an enlarged lymph node of a homosexual patient. In 1984, GALLO et al. Reported the alleged isolation of an identical retrovirus from CD4 lymph cells from homosexual patients, clinically diagnosed as suffering from AIDS. Bacterial et al. Co-cultivated these patients' lymph cells in question with fetal cord blood, and GALLO et al. Co-cultivated theirs with leukemia cells. Initially, these laboratory methods must raise doubts as to whether the isolation of a new human retrovirus is evident just by these data. GALLO et al. Stated that their allegedly isolated retrovirus caused the destruction of CD4 lymphocytes in those patients, whose heterogenic illness was taken as an after-effect of the CD4 cell destruction and so subsumed as AIDS. Besides, GALLO et al. Announced that in due time a vaccine would be available for the formation of antibodies against the discovered virus. Today, 15 years later, the question still remains open, whether high retroviruses actually do exist or whether the postulated retroviral HIV antigens as well as the postulated HIV reverse transcription are a matter of human protein molecules derived from cells in CO-cultured cell cultures used by both Barsineci et al. And GALLO et al. The most extensive investigations in this regard are owed to Eleni Papadopoulos-Eliopoulos and her group in Perth, Australia. In 1993 they published a review concluding that there is no evidence for the existence of high viruses. In 1994 Lonka demonstrated that all retroviruses, including HIV, are biologically inexistent and their phenomenology is based on laboratory artifacts. 4-6. Eleni Papadopoulos confirmed Lanka's interpretation in a recent comprehensive review. These fundamental counterstatements to the current HIV/AIDS theory have been strongly supported in the last few years. Upon investigations in order to develop a vaccine against HIV, it became apparent that the enrichment of presumed HIV-1 preparations, considered as pure, consist of proteins of the cell types used in the cell cultures, which resist a clean separation into presumed retroviral and cellular proteins, i.e. extracellular matrix proteins. Above all, these cell proteins also occur in the inside of extracellular particles, which have been misread as it seems as so-called high virions by the retrovirologists. 8-10. These findings were to be expected as GALLO et al., when developing the AIDS test, did not investigate the presence of cells' own proteins in the protein mixture, released during the CO cultivation of patients' lymphocytes and leukemia cells. Upon developing the ELISA and Western blot tests, it should have been imperative to consider proteins released from stimulated leukemia cells, not being mixed with patients' lymphocytes, and to differentiate these from the ones released only after addition of patients' lymphocytes. In view of this, it seems to be mandatory to re-evaluate the question of the specificity of the anti-HIV antibody test. What is the laboratory finding anti-HIV positive based on? In a series of preceding reports we have discussed this question in detail, 11-14. We came to the conclusion, the laboratory finding anti-HIV positive is primarily the expression of an autoimmune activation of the immune system linked to a persistent catabolic state of metabolism. In view of the fact that the diseases grouped under the term AIDS are limited to risk groups such as homosexuals, drug addicts, and recipients of blood products contaminated with parenterally transmitted hepatitis inductors, the question is raised, whether the anti-HIV test determines autoantibodies directed against cell envelope structures with a specificity to the body's own proteins of the host cells. It has been known for over 20 years that chronically active hepatitis, currently hepatitis B, hepatitis C, and autoimmune hepatitis without evident antiviral antibodies, react by the formation of autoimmune antibodies directed against cytoskeletal proteins of the liver cells. Thus, the raised anti-actin autoantibodies are pathognomonic for chronically active hepatitides. Johnson et al., in 1965, were the first to report on anti-actin autoantibodies. They described autoantibodies directed against smooth muscle cells and showed that this had to be considered as characteristic indication of lipoid hepatitis. In 1973 Gabuni et al. Demonstrated that autoantibodies directed against smooth muscle cells react with actin-containing microfilaments. Further investigations indicate that autoantibodies with anti-actin specificity are to be classified within the big group of autoantibodies against filamentous proteins of smooth muscle fibers. 3-18% of healthy individuals present low-titer autoantibodies against cytoskeletal proteins. High-titer anti-actin autoantibodies, on the other hand, are only found in patients suffering from chronically active hepatitis and/or biliary cirrhosis. In 1994, Burma's ETAL showed that both sera from patients with lupus erythematosus and from mice suffering from the same illness react with glycoprotein 120 and peptides of the postulated HIV-1 envelope. They further proved that control sera of healthy individuals and patients with other autoimmune diseases contain small amounts of the same autoantibodies. Last but not least, they showed that autoantibodies reacting with glycoprotein 120 do not possess antinuclear specificity. They refrained from investigating a specificity against cytoskeletal proteins of these autoantibodies. Evidence is given that the anti-HIV test does not indicate antibody formation against the postulated retroviruses as, during the last decade in Germany, not a single seroconversion has been observed in imprisoned drug addicts. All seropositive drug addicts acquired their anti-HIV positivity before their imprisonment. In opposition to this, seroconversion by hepatitis B inductors was recorded in intravenous drug addicts, 21 to 23. The same was also observed in hemophiliacs, i.e., despite continuous substitution with hepatitis-contaminated blood products, approximate a third of these individuals never become anti-HIV positive. This is characteristic for the individual response to autoimmune reactions against cytoskeletal proteins in the host cells, in which Gerard and Sen, Cal observed a polyreactivity. The individual autoimmune reactivity either appears at first contact or fails to appear even at multiple contacts. We conclude that a positive anti-HIV test does not indicate an antibody formation against retroviral HIV antigens. Low-titer anti-HIV antibodies are common even in healthy individuals. High-titer anti-HIV antibodies are pathognomonic in chronically active hepatitis. The anti-HIV test does not answer the question whether anti-HIV antibodies occur or not. The test differentiates between plenty equals positive and few equals negative. Rethinking as to reverse transcription. The error, taking proteins resulting from HIV isolation for retroviral proteins, dates back to 1970. The paradigm, that DNA codes information and programs relating to all physiological and phenomenological aspects of all organisms, resulted in the postulation of the irreversibility of the genetic flow of information for the synthesis of proteins, from DNA via messenger substance, RNA, to proteins. This was the crucial genetic dogma. Despite the proven reversibility in 1970, that from RNA DNA can remerge, this fact was postulated as an exception that proves the rule by stating the existence of retroviruses, qualified for this reversibility, which, at this time, were only considered as two more viruses, 26, 27. With the discovery of this enzymatic activity in all living cells, it soon became clear that the evidence of the function of reverse transcription from DNA into RNA was not a proof for the existence of retroviruses, because the genome of all eukaryotic cells is clearly marked by this activity, 28, 29. Retrospectively, it seems rather astonishing that in 1983 Montagnier and in 1984 Gallo still postulated a new retrovirus despite the fact that a new viral entity had never been isolated or described, according to the standard regulations in virology. As a matter of fact, the enzyme reverse transcriptase from OHIVO has never been isolated or described, but only inferred from functions to its existence, when new formation from DNA into RNA was proven by laboratory techniques. Since 1985 it has been known that the reverse transcription plays a decisive role in the maintenance of the structure of the genome, by repairing chromosome fractures and, especially, by limiting the loss of chromosomal end components, the telomeres occurring at cell replication, 30 to 33. The respective enzymes for this kind of reverse transcription, the telomerases, dispose of a type-specific RNA matrix for the formation of the repeating telomere units. Somatic human cells, that do not belong to the reproductive path, cannot adapt to the shrinking of their telomeres when replicating and so cease the replication at a certain degree of depletion. Up to date, the influence of nucleoside Analogues on the action of telomeres at replication has obviously not been investigated. We could trace only two publications, in 1996, which describe an in vitro investigation of nucleoside analogues inhibiting the telomerase activity. In our view, the knowledge, already gained in 1980, on the vital physiological function of reverse transcription, should have led to a rethinking as to the establishing of nucleoside analogues as pharmacological inhibitors of the reverse transcription of the postulated Hiv viruses and, according to knowledge of that time on the physiological function of the reverse transcription, it should have been rejected. 34-35. What is the decrease of CD4 lymphocytes in AIDS based on? The decrease of the circulating CD4 lymphocytes in the bloodstream during progressive immune deficiency in AIDS has generally been explained by the progressive destruction caused by Hiv viruses. 4 years ago, Carbonari et al. Showed in an in vitro investigation that the apoptosis of the lymphocytes in AIDS patients is mainly related to CD8 T cells and CD19 B cells. Finkel et al. Then pointed out that apoptosis concerns mainly bystander cells and spares supposedly infected cells from so-called HIV and SIV lymph nodes. These reports remind us of Fossey's classical publications of the 70s, in which he and his working group clearly demonstrated that, in persisting hypercortisolism, an increasing number of CD4 cells leave the bloodstream and can thus activate B cells in the marrow. 39-44. The migrated CD4 cells return to the bloodstream upon dropping to normal values of the cortisol level. At the beginning of 1995, Wei and Ho et al. Published a report in which they declared that the extremely fast multiplication of Hi1 viruses produces a raised turnover of CD4 lymphocytes. 45-46. Towards the end of 1996, Wolders et al. Showed that the telomere length of CD4 lymphocytes in anti-HIV positive individuals remains normal, whereas the one of CD8 cells decreases. During the latest International Congress of Leading HIV Scientists, the long-term criticism of the HIV/AIDS theory has been confirmed. Despite intense and precise investigations, there was no proof of a pathophysiological mechanism explaining the different reaction of CD4 and CD8 lymphocytes to the postulated retrovirus HIV. It was literally stated, the riddle of CD4 cell loss remains unresolved. Paul Johnson of the Harvard Medical School in Boston voiced in a disillusioned way the helplessness of the conventional AIDS scientists. We are still very confused about the mechanism that leads to CD4 depletion, but at least now we are confused at a higher level of understanding. In other words, Fossey's pioneering work, based in the 70s, on experimental traumatology fell into oblivion. Calvano clearly documented in a review published in 1986 that the selective depletion of CD4 lymphocytes is induced by neuroendocrine mechanisms in traumatic conditions such as injuries and burns, whereas its proportions depend on the degree of hypercortisolism. It remains enigmatic why Fossey, after having joined the AIDS research, never again mentioned his own reports. What does the viral load measure? Immediately, after the publication of Wei's and Ho's reports in January 1995, 45-46, in which they put forward the hypothesis that Hiv viruses multiply at raving speed, destroying a similar number of CD4 helper cells, quantitative tests based on the genetic multiplication method PCR were introduced, and so a large number of HIV in the bloodstream was postulated. It has been well known among HIV scientists that the so-called viral load, i.e. the measurement of the viral load, is no evidence of the entire virus genome or intact viruses. The viral load measures short components of the messenger substance RNA, attributed to the Hiv viruses. Because the Hiv virus genome per se never could be described, it is impossible to designate these RNA fragments as viral. Going through the records of the presumed characterization of HIV, it can be inferred that all components, proteins and genetic substance, attributed to HIV, are of pure cellular origin. 3-7. Therefore, the results of the viral load can only have an indirect significance, such as the measurement of an increase or decrease of cellular RNA, as it can be observed as increasing in catabolic conditions of cell disintegration and decreasing in anabolic conditions. However, these results cannot be considered as clinically relevant as, besides the technical inadequacy, control investigations with both non-positive defined healthy and ill individuals have never been published. The polymerase chain reaction, PCR, is a technique for a manifold multiplication of short DNA fragments, developed by Nobel Prize winner for chemistry, Kary Mullis. Upon measuring the viral load, the RNA fragments in the bloodstream first have to be converted into DNA and then multiplied as such. The single, developing technical steps of this method are prone to failure. The slightest impurity, drugs, such as heparin and other substances, interfere with a reproducible functioning of the PCR method, especially with quantification. Kremers, the inventor of this method, does not miss any occasion to criticize the application of his technology in the context of AIDS. Furthermore, it is concealed that it does not make sense, either practically nor theoretically, to initially multiply manifold fragments of genetic structure and then to postulate their manifold presence. In case they were actually present in the blood samples, it would cause no problem to prove their existence by simple, quick, and cheap standard methods, and, if de facto, viruses did exist in the bloodstream, scientists certainly would have been successful in making them visible. Hence, up to date, no scientist claims this achievement, a fact which has been confirmed under coercive evidence by the German Health Ministry in 1996. After the report of a produced positivity in the viral load during a vaccination test with proteins of a previously negative defined test person, it is now frankly admitted that repeated wrong positive results in the viral load are quite a well-known phenomenon. Impairment of energy formation in mitochondria by nucleoside analogues such as AZT, azidothymidine, zidovudine. AIDS patients quite often demonstrate a weakening of their skeletal muscles. Up to 1990, this was considered a high virus-caused impairment of muscles. In 1990, Dalaka's et al. Demonstrated that this kind of muscle disease is due to an administration of AZT, weakening the mitochondria within muscle cells. With the excessive release of free radicals, the mitochondria are affected in their function of forming ADP as key substance in metabolic energy. Hayakawa et al., in 1991, demonstrated important changes in the mitochondrial DNA, mtDNA, in the liver of mice after the administration of AZT. The final sentence of this paper reads, however, for AIDS patients it is urgently necessary to develop a remedy substituting this toxic substance AZT. These results were confirmed by histochemical methods in the same year by Chariot and Gherardi. The toxicity of nucleoside analogues in the treatment of viral diseases was thoroughly dealt with in the following years, and it was proven that the toxic effect causes multi-organic impairments in heart muscle, brain, and kidney, as well as in liver and pancreas. Further, it was shown that successor drugs of AZT such as DDL and DDC cause the same mitochondrial impairment. Since 1991, it would have been mandatory that not only the pharmaceutical industry but also the registration authorities seriously consider these impairments caused by long-term administration of nucleoside analogues and provide proof of the incoherence of AIDS patients' death with this drug treatment. In general, this obligation has been avoided and now they face upcoming connected liability questions. HIV proteases inhibitors, a new therapeutic principle in the prevention and treatment of AIDS. According to the HIV model, long precursor molecules of proteins along the multiplication process have to be cut at certain interfaces in order to create functional HIV proteins upon which, ultimately, new high viruses form. Synthetically produced short protein molecules, reproduced after the interface to be cut from the precursor protein but which cannot be cut, should, according to the model again, inhibit the natural activity of the HIV protease and thus prevent the formation of new high viruses. As a matter of fact, the HIV protease has not been isolated, but has been reconstructed by genetic engineering, upon which it was observed that this enzyme is very similar to the human digestive enzyme, pepsin of the class of the aspartate proteases. The problem of the model is that the one and the very same HIV protease would have to be cut at completely different interfaces in order to form functional proteins and, ultimately, HIV. Practically, this is not conceivable and has been explained as, enzymes do not have a high sequence specificity, although it has been postulated that, a therapeutically applicable inhibitor has to be specific, and should not inhibit human enzymes of this class of substance. Considering these explanations of the head of the chemical department of the scientific laboratories at Bayer's, it becomes obvious that, theoretically, it is not possible to exactly target the postulated HIV protease. Further, it is impossible not to interfere in the cellular processes of integration and disintegration of a variety of proteins. The inhibition of the active protease in AIDS per se makes sense. However, the pharmacological administration of high doses of distinct aromatic substances is a non-physiological measure, connected with serious side effects which excludes their pharmacological use. Indeed, up to date, the pharmacological HIV protease inhibitors prove to be connected with side effects, which demand the absolute necessity of their replacements by phytotherapeutic mixtures. Apart from side effects such as kidney stones, damage of the liver, an increase of diabetic impairment of metabolism, CMV retinitis, and hemolytic anemias, these protease inhibitors, after a short-term administration, also demonstrate a loss of effect on the inflammatory process, which was misinterpreted as a result of an acquired resistance by HIV as well as an incompatibility with many drugs, especially with the ones of the group of cytochrome P450 inhibitors and inductors. Nutritional possibilities in the prevention and treatment of AIDS. Looking at the formula of structure of the synthetic protease inhibitors, it becomes obvious that these are artificially produced aromatic compounds. As we have suggested lately, polyphenols as well as tannins and flavonoids are phytoprotective substances against harmful external influences. As aromatic substances, they cannot be synthesized by the animal organism. The nutritional supply of a variety of phytopolyphenols to the animal organism has the function of operating as a redox buffer and rebalancing oxidative stress conditions with their catabolic alteration of metabolism to the anabolic-catabolic state of equilibrium. Flavonoids and tannins are effective with respect to 1. Inhibition of lipid peroxidation, 2. Scavenging of oxygen radicals, 3. Binding and inactivation of pro-oxidative transition metals such as Fe and Cu, 4. Binding of proteins including attenuation of their enzymatic activity, protease inhibitors. Upon these reductive activities, flavonoids and tannins are oxidized themselves. A well-known example is the reduction of vitamin E by vitamin C or coenzyme Q. These mechanisms are at the beginning of a cascade of recycling. This example demonstrates that the multitude of almost 5,000 different flavonoids and tannins is used to overcome the oxidative state of the X-antioxidative molecules at the end of the cascade of recycling, by transferring it to a variety of native molecules. The stress-induced state of catabolic metabolism in AIDS is in the center of the pathogenesis. The correction of the connected whole-body inflammations, caused by oxygen radicals and protease activation, is a compelling preventive and therapeutic action which urgently demands the use of phytotherapeutic polyphenol compounds. Possibilities and limits of treatment of hepatitis in anti-HIV positive individuals. Asymptomlessness and the stress-induced activation of liver inflammation in healthy individuals are characteristic of parenterally transmitted inoculation hepatitis, hepatitis B and C. The classic example for this occurrence is post-transfusional hepatitis caused by blood and blood products of clinically healthy blood donors. At the occasion of a study, made in the early 50s at the blood transfusion service of the Swiss Red Cross on recipients of lyophilized pools of mixed plasma of 50 to 70 healthy blood donors, it was observed that this caused serious, sometime even lethal hepatitis in many ill recipients, 64 to 66. It is emphasized that in a contaminated organism with parenterally transmitted hepatitis inductors, now called hepatitis B and C, the aim of treatment has to be reduced to just reach a normal state of health. The administration of viruside, cytotoxic drugs is not able to eliminate these inductors from the organism. Proceeding from this knowledge, in Poland, for 2 decades, Brzozko et al. Have been collecting data with the Tibetan prescription of phytotherapeutic formula, PADMA 28. They showed that this phenol-rich plant compound is able not only to reduce the serum level of hepatitis B antigens in hepatitis B patients but also to augment the serum level of hepatitis B antibodies. At the same time, an amelioration was observed in these patients regarding their clinical condition and the biochemical and histological results from their hepatitis. Based on these pioneer results, today, in patients suffering from chronically active hepatitis, the substitution with phytopolyphenolic mixtures has priority over other treatments. How does the nucleoside analogues treatment of AIDS patients influence their course of disease? After having examined 8 reports on HIV-positive long-term non-progressors, who stayed clinically symptomless for over 10 years, we realized that, without exception, they had not been treated with nucleoside analogues, 68 to 75. We consider this as a confirmation of our above-mentioned caution as to the prophylactic and therapeutic administration of these cell toxics, originally developed for treating cancer, in the autoimmune course of disease and AIDS. Nutritional supply of polyphenolic mixtures as basic treatment of anti-HIV positive individuals and AIDS patients. As initially showed, a positive anti-HIV test is an indication of an augmented formation of autoantibodies against cytoskeletal proteins, i.e. actin. This condition is pathognomonic for chronically active hepatitis. AIDS, a serious immunodeficiency syndrome, is the expression of a persistent hypercatabolic state of metabolism along with a stress-induced whole-body inflammation. A successful treatment of such conditions consists of the nutritional supply of a sufficient quantity of antioxidative and antiproteolytic phytophenolic mixtures, consisting of flavonoids and tannins. As neither the animal nor the human body are able to synthesize aromatic compounds, they are fully dependent on a sufficient supply of anabolic effective phytopolyphenolic mixtures, in order to adjust catabolic states of metabolism. These mixtures are present in drugs made of teas and spices. Padma 28 proved to be the most effective one. Additionally, it is recommended to balance other possible states of deficiency of vital nutritional components such as polyanions and essential fatty acids. Completing this review, we came across the publication by Padian et al., which remarkably emphasizes the insignificance of heterosexual intercourse in transmitting HIV. In this study, extended to 10 years, the authors say, male-to-female transmission was approximately 8 times more efficient than female-to-male transmission, and male-to-female per-contact infectivity was estimated to be 0.0009. Obviously, AIDS is not a viral venereal disease, but an inflammatory autoimmune process. Did Dr. Gallo and his colleagues manipulate the AIDS test to order? The hunt for the virus has degenerated into clean torture with fatal result. By Heinrich Kremer. Continuum Summer 1998. Who, for given reasons given below, casts doubt on the theory that HIV causes AIDS, is often confronted with the question, if it did not, how is it that a patient who has been diagnosed as HIV positive by the test sooner or later goes on to develop AIDS? To which the AIDS skeptic usually replies that a HIV positive laboratory result, an arbitrary defined characteristic, is part of the clinical diagnosis AIDS. This exchange does not advance the argument very much as to whether AIDS and HIV are scientifically speaking biological entities, and if between them a biological cause-effect relationship is possible. In other words, if either the term AIDS or the term HIV, or neither, represents conceptually independent entities but rather purely semantic constructs, then biologically there can be no cause and effect relationship between these two terms, i.e. between the postulated pathogen HIV and the supposed definable disease entity AIDS. The causative factor, the retrovirus HTLV3, later termed HIV, was introduced by Robert Gallo in 1984, then a retrovirologist in the tumor biology laboratory in the National Cancer Institute at Bethesda. On May 4, 1984, together with collaborators from his own laboratory and other research centers and hospitals as well as workers at the pharmaceutical company Lytton Bionetics, he published 4 basic papers in Science. These supposedly described the identification, isolation, and continuous production of a newly discovered type of retrovirus, since 1987 called HIV, as well as the serological analysis of this HIV and of tests capable of detecting antibodies to HIV in the sera of patients with AIDS or pre-AIDS. The simultaneous publication of these 4 papers by Gallo et al. Was shortly preceded by a patent application for HIV antibody tests and by Reagan's U.S. Health Secretary's announcement at a press conference attended by Robert Gallo himself before the world's media that Robert Gallo and his team had discovered the probable cause of AIDS. The first Science paper of May 4, 1984 begins with the fundamental assumption: epidemiological data suggest that the acquired immunodeficiency syndrome, AIDS, is caused by an infectious agent that is horizontally transmitted by intimate contact or blood products. The word probably employed by the U.S. minister only a few days before was no longer mentioned by Gallo et al. The fourth and last science paper of that date ends with the conclusion, the data presented here and in the accompanying reports suggest that HTLV3 is the primary cause of AIDS. HTLV3 equals HIV. Gallo et al.'s conclusion proves that they did not postulate a direct cause and effect relationship between HIV and AIDS, declaring HIV to be only the primary cause of AIDS, although the disease is manifested by opportunistic infections, predominantly Pneumocystis carinii pneumonia, and by Kaposi's sarcoma. The underlying disorder affects the patient's cell-mediated immunity, resulting in absolute lymphopenia and reduced subpopulation of helper T lymphocytes, OKT4+. Gallo et al. By no means, therefore, postulated that HIV was the direct cause of AIDS, rather, they only claimed HIV is the cause of AIDS. AIDS equals acquired immunodeficiency equals reduced subpopulation of T helper lymphocytes. The syndrome S, manifested by opportunistic infections, OI, mainly Pneumocystis carinii pneumonia, equals PCP, and Kaposi's sarcoma, equals KS, was presented by Gallo et al. Like commonplace as the necessary consequence of AIDS. The scheme of Gallo et al. Is as follows. 1. HIV causes AIDS as a consequence of the infection and sooner or later the destruction of T helper lymphocytes. 2. As a consequence of the decrease of cellular immunity, the control of opportunistic pathogens and cancer cells by T helper lymphocytes breaks down, as a result of which, syndrome S develops. The short version of Gallo et al.'s plague formula is HIV equals AIDS equals S. The two-part causal chain HIV causes AIDS actually turns out to consist of 3 parts, and Gallo et al.'s claim that HTLV3 equals HIV is the primary cause of AIDS is a fusion of 2 hypothetical causal assertions, and a fictitious end-effect assertion. This is because Gallo et al.'s published data say nothing about whether AIDS really does cause S. They can at most suggest a cause and effect relationship between HIV and AIDS. Whether S can be the result of AIDS is for several reasons highly doubtful. S is somewhat chameleon-like due to numerous redefinitions undergone, so that the existence of S as a separate disease entity, in the sense of a biological disease entity, can no longer be rationally made out. Individual, defined diseases, which initially made up part of the syndrome were years later expressly removed again. In the end, a wild collection of 29 old infections and non-infectious diseases has been collected together to constitute the syndrome S, of which several are part of S even if the HIV status is negative or indeterminate. The latter means that AIDS cannot be the cause of S because AIDS is supposed to be the result of HIV, in order that Gallo et al.'s plague formula HIV equals AIDS equals S as a causal chain is upheld, yet AIDS due to different reasons can exist independently of HIV. Nothing is given whereby AIDS must be the cause of S. AIDS and S could, instead, have a common cause which need have no causal relationship with a hypothetical retrovirus HIV. The pretense of a pseudo-biological cause and effect relationship expressed by the plague formula HIV equals AIDS equals S has made a leading AIDS critic, who has presented the most comprehensive clinical analysis of the AIDS phenomenon, say AIDS, in short, has become a schizophrenic disease. How then, can a semantic construct of a collection of mostly contradictory diseases be the result of a supposed biological causal chain, which itself in turn is made up of hypothetical constructs as cause and effect factors? Because the premises and conclusions which underlie Gallo et al.'s plague formula can be falsified convincingly. Gallo et al. Have claimed that epidemiological data prove that an infectious agent is the cause of AIDS, and AIDS is the cause of S. Essentially, Gallo et al. Arrived at this conclusion from the findings of the CDC that S, OI, mainly PCP and KS, is significantly connected with very frequent promiscuity and predominantly receptive anal intercourse in homosexual men in the metropolitan areas in the U.S. However, this conclusion only demonstrates the arbitrary and selective interpretation of the clinical data by the CDC and Gallo et al. Highly promiscuous and predominantly receptive, unprotected, anal intercourse are specifically indicators simultaneously for infectious and non-infectious causal factors for S, OI, mainly PCP and KS, as well as AID, decline in T helper lymphocytes in blood serum. The conclusion of a new infectious pathogen and simultaneous exclusion of all non-infectious causal factors is by no means compelling, although it determines to this day the theory that HIV causes AIDS. Highly promiscuous behavior and predominant receptive anal intercourse closely correlate with consumption of sexual stimulants, above all amyl and isobutyl nitrites. 95% of homosexual men in the U.S. report regular use of nitrite. Nitrite inhalation relaxes the smooth anal muscles, raises blood flow to the penis, raises pain threshold, heightens orgasm, and unleashes a mild state of intoxication in the brain. Nitrite use predominantly but not exclusively became known in homosexual sex partners, and has been approaching ubiquitous in surveyed homosexual men in Western countries since the mid-70s. High-frequency promiscuity and predominantly receptive anal intercourse very often entails concomitant increased multi-infectivity and provocation of administrating antimicrobials, chemotherapy, antibiotics, antiparasitica, antimycotica, virostatica, and corticosteroids. The first report by the CDC in June 1981 of 5 diseased homosexual men being treated for PCP contains some clinical information of their medical history and medication, because at the time, the all-encompassing description AIDS, masking the real symptoms, had not yet become entrenched. The 5 homosexual patients had not had sexual relations between themselves. All of the 5 patients used nitrites, and all 5 had been treated with TMP/SMX. TMP equals trimethoprim, SMX equals sulfamethoxazole. The substance TMP/SMX, also known as Bactrim and Septrin, were introduced in the early 70s as a double chemotherapeutical folic acid inhibitor. Nitrite and SMX, a sulfonamide derivative, are strongly electrophilic oxidizing agents. Both oxidize ferrous iron in hemoglobin to ferric, and thereby reduce oxygen binding capacity of red blood cells. This causes methemoglobulinemia, a progressively life-threatening deficiency in oxygen supply into the respiration chain of the mitochondria. The latter are former bacteria, which, as multifunctional organelles, supply energy to the whole cell in form of adenosine triphosphate, ADP, produced in oxidative phosphorylation. Oxygen-dependent ADP synthesis and its resulting oxygen metabolites control the cell division cycle. If too little oxygen is transported to the respiratory chain, the ratio of oxidative ADP production in the respiration chain, normally about 90%, may become inverted in favor of the non-oxidative ADP production, normally about 10%. Latest experimental findings suggest that the redox balance controls the genetic expression of proteins for the enzymes of the non-oxidative ADP production, glycolysis. Under normal physiological conditions, there is a rhythm of phase-linked change between oxidative energy production in the mitochondria and the change to non-oxidative glycolysis during the late stage of cell division, the S phase of mitosis. If, through lack of oxygen under conditions of methemoglobulinemia, the genetic expression of glycolytic enzymes is not sufficiently inhibited, the cell may, despite intact mitochondria, and the presence of residual molecular oxygen, switch to permanent non-oxidative glycolysis and cationic load reversal. This results in unrestrained cell division, which may ultimately lead to transformation to a tumor cell. Along the oxygen transport route in the bloodstream, conditions in the most minute capillaries with a diameter below 100 nanometers, because of altered partial pressure of oxygen, are particularly favorable for the oxidation of the red hemoglobin, which can only bind oxygen when being in reduced form. Through diffusion and association to essential fatty acids through transit routes of the basic tissues, it can deliver oxygen to individual cells. The mechanism of unrestrained activation of cell division, hyperplasia, in methemoglobulinemia, may, therefore, following hyposemic stress, above all in the smallest capillaries, affect the cells of the walls, the endothelial cells. These endothelial cells are in direct contact with the hyposemic red blood cells. If hyperplastic conversion of endothelial cells occurs, that is called Kaposi's sarcoma. On the other hand, especially in rapidly dividing cells such as in thymus matured precursor cells of T helper lymphocytes, ADP production can decline to a critical value, if oxygen turnover is reduced permanently even by a small amount. This is a control mechanism, which in turn may affect the rate of mitosis. This interaction of hemoglobin oxidation by nitrites and antimicrobial drugs with oxidative phosphorylation may, in a situation of increased simultaneous consumption of T helper lymphocytes as a result of slowing maturation of T helper lymphocytes, be in part a cause of AID. This chain of causal events is also supported by the frightening possibility that nitrites may turn most classes of antibiotics into carcinogens. Excessive antibiotic consumption, whether prescribed or not, in a study 40% of male homosexuals admitted preventive use, in conjunction with nitrites is a frequently encountered pattern of behavior among male homosexuals, especially in the large urban areas in Western countries. Hyposemic stress can, therefore, explain the contradiction of simultaneous appearance of malignant hyperplasias, KS, lymphomas, and opportunistic infections, mainly PCP, in homosexual men, approximate 2/3 of AIDS cases in Western countries, excluding covered homosexual AIDS patients estimated by Orthodox AIDS doctors to amount to 50% of so-called heterosexual risk groups, without ever introducing a hypothetical retroviral cause to explain the pathophysiology. In contrast to this clear finding, GALLO et al. Tried to resolve the clinical contradiction between OI and KS by constructing a new retrovirus HIV. GALLO et al.'s so-called retroviruses HTLV-I and HTLV-2 are said to cause rare forms of leukemia, i.e. cancers of the white blood cells, whereas HTLV-3, equals HIV, is said to kill T helper lymphocytes. This concept has completely failed. The cytopathic effects of HIV demonstrated by GALLO et al. Have turned out to be laboratory artifacts. GALLO et al.'s claim that HIV kills T helper lymphocytes could, despite changing the theories, not be confirmed. The disease theory HIV causes AIDS is itself based on several serious clinical misconceptions. 1. The agent causing PCP is not, as GALLO claimed, a protozoan. The etiology according to which after the destruction of T helper lymphocytes by HIV infection, carinae pneumocytes, the cause of PCP, could escape control by T helper lymphocytes and multiply unrestrictedly, is objectively wrong. Such protozoa simply do not exist. What is involved are microfungi that are inhaled in the air, and which, for example, in the case of increased cell decay following hyposemic metabolic changes, including AIDS without HIV, find fertile terrain in the alveoli of the lungs. In this way, a harmless fungus, saprophyte, becomes the dangerous cause of PCP. 2. Contrary to what GALLO et al. Claimed, T helper lymphocytes do not suppress the growth of cancer cells, because cancer cells do not have antigens through which T helper lymphocytes could identify them. This means that the hypothetical destruction of T helper lymphocytes by HIV and the ensuing disappearance of the suppression of KS cells cannot be the cause of KS. The predicted increase of all other types of carcinoma in AIDS patients resulting from the disappearance of the surveillance of cancer cells after the postulated destruction of T helper lymphocytes by HIV infection did not occur. 3. Contrary to the assumption of the CDC and GALLO, the hypothetical HIV infection of T helper lymphocytes, despite the postulated essentially alarm function of T helper lymphocytes also for antibody production by B plasma cells, did not result in destroying defense capacity against all microbes. Unlike patients with impaired immune functions, e.g. intensive care patients in whom mortality following typical bacterial infections is up to 80%, strikingly in the immune deficiency syndrome AIDS, bacterial infections are rarely seen. The CDC under the category AIDS indicator diseases states explicitly for bacterial infections, frequent or repeated, not applicable as indicator of AIDS in adults/adolescents. 4. A fundamental pillar of the disease theory of GALLO et al. According to which HIV causes AIDS, is severely dented by the actual epidemiological situation over the 15 years 1982 to 1997. For example, In 1997 the German AIDS Center registered 2,736 KS cases in total, with 2,505 KS cases in the category homosexuals. The remaining KS cases were in heterosexual risk groups or no information on risk group. On average, therefore, there were 15 KS cases a year, which were not primarily classified as homosexual. Because homosexual intravenous drug users are classified as intravenous drug users and at least 50% of the patients classified as heterosexual men and not known were subsequently reclassified as homosexuals, this is of the order of magnitude to be expected for KS cases classified as non-homosexual men. Corresponding epidemiological data for the prevalence of KS are available for other Western countries. Gallo et al.'s formulation HIV equals AIDS equals S is not, therefore, found to be true. AIDS, measurable decline in lymphocyte population in the blood, especially T helper lymphocytes, though it can occur in all members of high-risk groups, is evidently not the cause of S, OI, mainly PCP and KS, because S can, first, occur without AIDS, and secondly, the combination of S with KS should, if the theory were correct, not exclusively be limited to homosexual patients. If, therefore, S is not necessarily the result of AIDS, what then is the common pathogenic indicator of AIDS patients as defined by Gallo et al. To be high-risk groups? The common factor of AIDS patients, without necessarily resulting in S, is obviously the unusually high uptake of strongly oxidizing substances, mitogens, and the huge variety of exogenous extraneous cells such as red blood cells, activated lymphocytes, or sperm cells from individuals, allogenic stimulation. It is beyond doubt that this oxidative stress, i.e. pro-oxidative versus antioxidative metabolism, of high-risk groups, can overload the detoxification capacity and waste disposal capacity of the body, which is furthermore supported by the finding that asymptomatic HIV positives belonging to high-risk groups show a strong shift from reduced to oxidized glutathione. The glutathione system is essential for the removal of oxygen-free radicals, especially in the mitochondria. The oxidation of the central molecule of glutathione, cysteine, to cysteine, in a chain reaction reduces the buildup of glutathione and accelerates the destruction. It follows that the systemic decline of glutathione concentration in HIV positives can be due to both reasons, because of decreased synthesis and increased disposal. The oxidative stress to which AIDS patients are subjected would lead to cellular anomalies in many cells, including lymphocytes, resulting in opportunistic infection, immunological abnormalities, and neoplasia. Does this finding of the overload of redox potentials in members of high-risk groups mean that HIV, too, or rather the anti-HIV antibodies are the result of oxidative bombardment on the cell-mediated immunity of the high-risk groups? A specific load value of the diminution of the reduction force in the body of members of high-risk groups is hepatitis type B, in particular, in the chronically active form. Gallo et al. Postulated in the first paragraph of the first publications in Science of May 4, 1984, except for the first rebutted premise, epidemiological data suggest that the acquired immunodeficiency syndrome, AIDS, is caused by an infectious agent, and the second, rebutted, premise, AIDS necessarily leads to S, a third premise, although patients with AIDS or pre-AIDS are often chronically infected with cytomegalovirus or hepatitis B virus. For various reasons these appear to be opportunistic or coincidental infections. This claim stands the clinical history completely on its head. High-risk groups, in Gallo's definition, homosexual men with multiple sex partners, intravenous drug misusers, hemophiliacs, blood transfusion recipients and close heterosexual contacts of members of these high-risk groups were long before the so-called sudden arrival of HIV, 1978, recognized to be the most severely hepatitis B-affected groups of patients. Hepatitis inducers, nowadays thought to be hepatitis B, hepatitis C, appear to be thousands of times as infectious in clinical settings as HIV and represents a much more prevalent medical problem. Hepatitis B, due to various pathophysiological reasons, especially in the chronically active form, contributes significantly to oxidative stress, by restricting waste disposal and detoxification, and overloading of redox potentials. The body tries to compensate for this by increasing cortisol production. When this ultimately fails, hypercorticolism persists in a damaging way. A hypercatabolic metabolism results from this, i.e. excess cell decay versus buildup. Cortisol as synergizer for a number of hormones and mediators affects activation of cyclic adenosine monophosphate, CAMP, and a displacement of the CAMP/cGMP ratio as principal indicator for increased cell turnover. The net effect is a dampening of cellular immunity and activation of humoral immunity. Resulting from the increased cell turnover, the decreased disposal of cell debris, because of the dampened cellular immunity (AID) and the strengthened autoimmune activity, a significantly increased formation of autoantibodies occurs which above all specifically bind to cytoskeletal proteins and extracellular proteins of the cell matrix as antigens. Concluding, it is fair to assume that Gallo et al. Took these attributes of high-risk groups into consideration, namely 1. The excessive oxidative, mitogenic, stress. 2. Allogenic stimulation by foreign cell components. 3. The sharply increased antigen autoantibody load together with suppression of T-cell-dependent immunity brought about by synergistic effects of persistent corticolism with resulting change in CAMP/cGMP ratio. In their original paper, Detection, Isolation, and Continuous Production, Gallo et al. Were only able to cite indirect phenomena, such as reverse transcription, ultra-thin layer electron micrographs, banding of protein mixtures at given densities, which according to the established rules of virology are not acceptable as evidence for the existence of a virus or less a retrovirus, because these indirect phenomena can also be obtained in the absence of any viral entity under certain cell culture conditions. Then the question becomes increasingly pressing: how did Gallo et al. Manage to produce a protein mixture in cell cultures and in the test tube, which is the substrate in the AIDS test when in contact with serum of people in high-risk groups, resulted in a given rate of antigen-antibody reaction for single proteins? Gallo's papers, though written in highly technical language, do not reveal this secret of test constructing. Only in 1987, when the disease theory HIV causes AIDS led to the introduction of a highly toxic DNA chain terminator, azidothiamidine equals AZT equals retrovir, was some light shed on this matter when two of Gallo's former collaborators and co-authors of the original publications in Science of May 4, 1984 revealed the essential details. Mongolis Cyril Sarnjadharan and Philip Markham, collaborators of Lytton Bionetics, Kensington MD, USA, published the biochemical methods used by Gallo et al. Whereby they manipulated the protein mixture, which due to self-defined conventions are said to be HIV antigens. To start with, Gallo et al. Biochemically prepared cell components obtained from members of high-risk groups according to the self-defined rules of retrovirus production. This procedure only from time to time and only transiently led to the production of unspecific phenomena as surrogates for the existence of a new retrovirus. Then they mixed lymphocytes from patients in high-risk groups with exceptionally rapidly dividing leukemia cells. This cell mixture was then subjected to the effects of certain biochemical substances. They go on to say that in vitro stimulation was achieved by mitogens or added cells, allogenic antigens. Certain manipulation of culture conditions improved the result, for example, CO cultivation of patients' cells with peripheral white blood cells, which were stimulated by mitogens, from non-infected donors. The virus isolation of cultured cells was also significantly facilitated by adding hydrocortisone to the culture medium. Knowing the specific antigen autoantibody status of high-risk groups patients, it is possible, therefore, to trigger, on demand, an antigen mixture appropriate to the autoantibody repertoire in serum from high-risk patients, in cell cultures of human lymphocytes, CO cultured with leukemic cells when subjected to specific biochemical manipulation. The apparent proof that in the antigen mixture one is dealing with retroviral proteins, brought about by the demonstration of a naturally occurring repair mechanism, reverse transcriptases, produced particularly copiously in cancer cell cultures to repair DNA and renew chromosome ends, hence CO cultivation with leukemic cells in Gallo et al. Cell culture, as well as proof of exocytotic virus-like particles, frequently occurring transport particles to expel intracellular components from mitogenically stimulated cells, as proof of isolation and continuous production of supposed retroviruses is misinterpretation. That Gallo et al.'s sensational discovery of a new retrovirus was in fact a laboratory artifact is made explicit by Gallo et al.'s expressly stating that HTLV-I, isolated from T cells in 10% of AIDS patients, and HTLV-2 from the family of retroviruses in AIDS patients, were also discovered and demonstrated. Later on, there was no further mention of HTLV-I and HTLV-2 being isolated from T cells of AIDS patients. Nor were there noticeable occurrences of leukemia in AIDS patients. The isolation of HTLV-I and HTLV-2 was a laboratory artifact due to the rules of retrovirus production of Gallo et al. By analogy, this finding accounts for HTLV-3 equals HIV as well. In effect, therefore, Gallo et al. Were adapting conditions which they knew to be conducive to antigen formation in the body of high-risk patients, to laboratory conditions. The difference is that in cell culture as opposed to the body of high-risk patients, no antibodies are present because the B plasma cells are absent. Then it is possible, at a certain arbitrarily fixed autoantibody level, to demonstrate an antigen-antibody reaction when the antigen mixture of the cell culture is brought in contact with sera of high-risk patients. This is exactly the principle employed in anti-HIV antibody tests. In mirror image fashion, the artificially produced antigens bind to the autoantibodies, whose presence was to be expected because of the well-known pathophysiological overload of high-risk patients. In describing the recipes of Gallo et al.'s, who covered their laboratory tricks behind the dust screen of patents, the irrational reduction of aid to the effect of a seemingly new infectious cause and the ignoring of the clinical effect of chronic hepatitis becomes apparent, as a claim used to create pressure to introduce the patented antibody test system of a new retrovirus found in the National Institute of Cancer. The laboratory finding of HIV positive, which may be diagnosed in those belonging to high-risk groups depending on the quantity and personal reaction pattern of antibodies, may also be made in rare cases in those not belonging to high-risk groups for a number of extremely diverse reasons. Gallo et al.'s expectations regarding the dynamics of the spread of HIV have, contrary to the horrendous predictions, not been fulfilled in the real biological world. In Germany, for example, according to official figures for the 15 years 1982 to 97, out of a population of 82 million, 60.000 have been notified as HIV positive, i.e. more than 99.9% of the population are personally not affected by HIV and AIDS. The official government forecasts, until now uncontradicted, spoke of there being more AIDS cases by 1996 than there were inhabitants. At least every other person was supposed to have died by 1996, unless a vaccine or drug against the absolutely fatal plague had become available. In the former East Germany, there have been a grand total of 252 cases in a population of 16 million, and that despite massive migrations, since the fall of the wall, up to the end of 1996. Over the past decade in the whole of Germany there has been a very constant 2 to 3.000 number of people diagnosed annually as HIV positive. 95% of these have been classified as belonging to the high-risk groups of homosexual men and 4-drug user. Homosexual 4-drug users are counted as ordinary 4-drug users. 5% of HIV positives are considered to be false positives, but cannot be identified as such by the test. At most 2,000 HIV positives develop AIDS annually, and 1,300 patients die annually of AIDS. Actual cause of death is not revealed. Of the supposed 60.000 HIV positives, figures are very unreliable because of unknown multiple reporting. 50.000 are still officially alive today. 54% of all AIDS patients gave their addresses to be one of the 6 largest cities, in which 10% of the general population also live. Opposed to that, in 90% of the remaining inhabitants only 44% of the notified AIDS cases occur. For example, the disease rate and death rate of HIV-positive hemophiliacs registered in these 6 cities is twice as high as in HIV-positive hemophiliacs living outside of those cities. In these cities, Berlin, Hamburg, Köln, Düsseldorf, Frankfurt, and München, the University Clinical AIDS Treatment Centers are located, which report the highest AIDS disease and death rates to the National AIDS Center. As the positions of collaborators, the AIDS ambulances and AIDS stations of these university clinics mostly are paid by the pharmaceutical companies, the connection between medicine and market, AIDS test, AIDS medications, becomes all too obvious. Very intriguing is the comparison between the capitalist West Berlin and the former socialist East Berlin. In the period of 15 years from January 1, 1982 to the January 1, 1997 in West Berlin, 2,2 million inhabitants, which make less than 3% of Germany's population, 3,083 AIDS cases have been registered, which are 20% of all German AIDS cases. In the same period, including 7 years of unification with West Berlin after the fall of the Berlin Wall 1989, in East Berlin, 1,3 million inhabitants equals 1,6% of the German population, only 152 AIDS cases are registered, which make 1% of all German AIDS cases. This very intriguing, by chance historical and model-like data proves wrong the premise of GALLO et al. That epidemiologic data suggest that the acquired immune deficiency syndrome, AIDS, is caused by an infectious agent. The disease rate when brought in connection with the whole population is obviously a very rare medical event, not dependent on a ubiquitous transmittable mass virus, but determined by lifestyle in a largely commercialized subculture and/or by uncritical medical intervention in Western society of superabundance. Or pathophysiologically spoken, AIDS patients come down due to a lack of power of reduction, caused by superoxidation and/or hypoxemia, in the midst of a redundant medical oversupply. To argue against GALLO et al. Refers to Africa, which is uncritically presented by mass media as the dying AIDS continent. 2. In this context, the world of facts seemingly is overwhelmed by a virtual, only imagined world of information. In Africa south of the Sahara, the annual increase in population was about 100 million inhabitants over the last decade, even though the latest report on the world population states that according to a lot of population experts in the Third World, the plague supported the birth planning more than any earlier programs. Due to the lacking medical infrastructure and low budgets in the healthcare system, in most states south of Sahara the average annual spending per head of the population for providing healthcare is $6, a single complete AIDS test, 2x ELISA test, 1x Western blot, costs much more than $6. The AIDS test is not widely used. Instead of this, the World Health Organization, WHO, transfers certain amounts of money to the health authorities of the various countries for AIDS education in order to get estimated incidental rates of HIV infection and AIDS cases which are not verified by the WHO. WHO experts use these estimates in calculations based on the supposed dynamic of distribution of the HIV plaque and present the resulting numbers to the world media as HIV infection and AIDS disease in Africa. Usually, in the subsequent media reports, the speculative HIV infections and AIDS diseases are lump-summed and wrongly reported as AIDS cases in Africa. This is the way the manipulated numbers of more than 20 million AIDS cases in Africa, ap 90% of the worldwide reported AIDS cases, came into existence without any substantial base of knowledge. The fictitious loom scene of a people murdering AIDS plaque in the global media village acted again, enhancing on the selling of AIDS tests and anti-HIV medications, euphemistically termed cocktail therapy, in Western countries, in a way that poor Africa unwillingly was misused to increase sales in the rich West. The data on the clinical, immunological, virological, and epidemiological progress since 1984 show beyond any doubt that the disease theory HIV causes AIDS has no concurrence with the biological reality. As a marketing strategy, GALLO's manipulated AIDS test has been extremely successful. But this at the cost of the health and life of uncounted children, women, and men who, from a medical ethic point of view, became victim to clean torture with case of death induced by the arbitrary medical death sentence of a HIV-positive result. Medical ethical behavior according to best wisdom and conscience must signify to make, out of your own, the effort to inform yourself on the basis of existing data about possible manipulations in diagnostic and therapy and to use the given alternative therapies instead of inducing fear blind with rage. Asterisk. Interview Heinrich Kremer. By Hans Joachim Ehlers. Rom and Zeit November/December 2001. We are biological hermaphrodites in the evolutionary scheme of life. Rom and Zeit, Dr. Kremer, you have written a sensational book Die Still Revolution der AIDS und Krebsmedizin, The Silent Revolution in AIDS and Cancer Medicine. First, a question about what AIDS has to do with cancer? Kremer, the appearance of a rare cancer form, Kaposi's sarcoma, was first reported 20 years ago among homosexual patients in their mid-30s in the USA. This was a sarcoma affecting the inner wall cells of blood and lymph vessels. Other homosexual patients either with or in most cases without Kaposi's sarcoma suffered from fungal infections of the lungs and other organs. These were linked to a high fatality rate, since specific chemoantibiotics proved a failure. Most patients developed cachexia, a loss of body cell volume that could not be offset by nutritional means. The common characteristic of these cancer and infection patients was functional loss of the cellular immune defense against intracellular disease pathogens, while the antibody defense against extracellular microbes remained completely intact or even increased. This disease constellation was later called acquired immune deficiency syndrome or AIDS. It was noticeable that this combination of symptoms occurred in exactly the same manner among patients with organ transplants who had been treated since the 1960s with the immunosuppressive agent azathioprine to prevent rejection of foreign organs. Thus the link between cancer and induced cellular immunodeficiency, AIDS, was known to physicians in 1981. Rom and Zeit, yet the clinicians reported at the time that previously healthy AIDS patients had not been treated by immunosuppressive measures. Kremer, these diagnoses were correct superficially, but they were far removed from reality. Up to the present, these erroneous diagnoses have led to one of the most absurd mistakes in modern medicine and one resulting in the most serious consequences. Due to the completely identical symptoms, it would have been absolutely logical to ask if substances with immunosuppressive agents and a cell toxicity action profile analogous to azathioprine could have been the cause of AIDS before having announced the appearance of a new fatal sex and blood epidemic. One would naturally have had to search for substances that had not been medically prescribed for immune system suppression, such as in the case of organ transplants. Rom and Zeit, were there any such substances? Kremer, yes. Addiction to poppers among homosexuals was rife in the metropolises of the USA and Europe during the 1970s. It involved inhalation of nitrogen gases as sexual doping agents for sphincter muscle relaxation during anal sexual intercourse and for extended penis erection. Nitrogen gases, amyl nitrite, and other agents were found in animal experiments to be extremely dangerous immunosuppressive substances. Anyone can read in medical publications on the first AIDS patients that they were all nitrite users. Nitrites and the aza group of azathioprine have a comparable nitrogen action profile. The substances groups form nitrosothiols and nitrosamines and inhibit fermentation activity in the respiratory organisms of our cells, the mitochondria. The result is blockage of oxygen-dependent cell respiration. The cells die or transfer to energy preparation typical of cancer cells through fermentation independent of oxygen. Numerous studies during the 1970s also demonstrated that promiscuous gay men had by far the highest infection occurrence among all risk groups in the USA and Europe. Since 1969, the chemoantibiotic cotrimoxazole, Septrin, Bactrim, that contains the substance trimethoprim as well as a sulfonamide, has been viewed as a wonder weapon against multi-infectious incidents. Promiscuous homosexuals were the risk group with the greatest consumption of cotrimoxazole. According to a statement by the world's greatest cotrimoxazole producer, the Swiss pharmaceutical concern Hoffmann La Roche, the drug is regarded as one of the most successful substances that has ever been developed. In reality, cotrimoxazole is one of the most dangerous substances. It is prescribed for more than 5% of the population each year. Due to the structural analogy of the nitrogen action profile for azathioprine and trimethoprim, the immunosuppressive characteristics of trimethoprim had already been tested on animals in England during 1970. The result was absolutely clear: trimethoprim, given in comparable doses as cotrimoxazole treatment among human beings, prevented rejection of skin transplants precisely as long as azathioprine. It was proved in 1971 that one of the most common AIDS indicator illnesses, systematic Candida fungus infections, appeared after cotrimoxazole treatment taken according to the usual dosage and length of prescription. It was demonstrated in 1981 that cotrimoxazole caused massive DNA damage in human cells immediately after a brief intake period at the outset of the 1980s. One administered antibiotics such as cotrimoxazole along with nitrogen gases in animal experiments. It developed cancer. Rahm and Zeit, were the necessary conclusions drawn from these findings? Kremer, absolutely not. Although the causes of AIDS were obvious, the gay male AIDS and cancer illnesses were explained as a mystery. Instead, it was postulated that there had to be a new virus causing the illnesses. Otherwise, one would have had to reckon on a pharmaceutical catastrophe with unforeseeable consequences. There were parallels in medical history. During the 1960s, a massive outbreak of muscular and nerve damage with high mortality appeared in Japan and was viewed as mysterious. Virus researchers maintained they had discovered a new virus as the cause of these illnesses. This disease theory was accepted worldwide in all medical textbooks. Years later, a few physicians noted that all these patients suspected to be infected by viruses had been treated with the enterovioform preparation from the Swiss pharmaceutical concern Ciba-Geigy. The preparation was withdrawn from commerce after liability suits, and no new cases of the disease appeared. The new virus had never existed. The anti-parasite agent enterovioform also had an action profile toxic to mitochondria similar to azathioprine, cotrimoxazole, nitrites, etc. Rahm and Zeit, in your book you document in detail that previous theories on the causes of disease and death involving AIDS and cancer are basically false. Why do virus cancer researchers dominate AIDS research to this day? Kremer, a crucial clinical phenomena surfaced in cases of Kaposi cancer patients with organ transplants. If azathioprine was discontinued, even tumors the size of chicken eggs receded without leaving a trace. This fact strictly contradicted the cancer theory dominating up to the present that cancer is triggered by an irreparable mutation of the DNA nucleus and that cancerous tumors can only be combated by operations, chemotherapy, and radiation. Transformation to the cancer cells is regarded as irreversible. The disappearance of azathioprine-induced Kaposi's sarcoma among organ transplant patients endangered the theoretical structure of the profitable cancer industry. In 1971, then U.S. President Nixon called for a war against cancer, and set in motion the greatest capital investment in medical history up to that point in time. It was primarily retrovirus cancer researchers who profited from this, though they have been totally unsuccessful to this day. The appearance of Kaposi cancer among homosexuals and patients with immune systems weakened by toxic drugs brought the retrovirus cancer researchers to a simple but extremely viable idea from a commercial standpoint. As in Japan, laboratory techniques had been developed in order to fake the existence of retroviruses that one could indeed demonstrate with electron microscopy in birds and mice but never in human cancer cells. Researchers bred immune cells, which were reduced in the blood of AIDS patients, alongside leukemia cancer cells. In addition, this cell culture was stimulated with highly oxidizing substances and the growth factor interleukin-2. The stress proteins exported from this cellular mix and a repair enzyme protein were explained exclusively as indirect markers for infection of these cells by a new retrovirus. Later it was also possible to determine the synthesis of this proteins induced by pro-oxidative cellular stress in other human cells. Thus one produced the assumed new immune deficiency virus, HIV. In other words, as in the Japanese example, the new virus had never existed. However, one brought this human test proteins into contact with human sera, and it logically prompted an antigen-antibody reaction, just as with other foreign proteins, though also in sera of healthy test subjects. Thus one knew that these reacting proteins, stimulated in AIDS and cancer cells with all possible antibodies, also reacted in blood serum of healthy patients who were beyond suspicion of having been infected by the presumably new fatal HIV. Yet, since one also knew that most AIDS patients showed increased polyspecific antibody levels, the test reaction threshold was set at a specifically high antibody level. In this way was seemingly proven in a logical cycle conclusion that only the test subjects from risk groups with more or less pronounced cellular immune deficiencies reacted positively to this anti-HIV antibody test. That is, they had to be infected with HIV according to this topsy-turvy logic. Using this manipulated AIDS test, millions of human beings were selected as assumed victims of the fatal sex and blood epidemic HIV during the past 17 years, and countless people were killed by aggressive cellular toxins based on the medical assertion that one was extending the lives of these patients. Rahm and Zeit, did these lab tricks suffice to convince the scientific community? Kremer, no, a seemingly plausible theory was formulated, at least considering the denial of pharmaceutically contributed toxic causes. It held that the apparent virus linked the cause of AIDS to the cause of cancer. Retrovirus cancer researchers postulated from 1983 on that retroviruses were not directly settled cells transformed into cancer cells, but that the HIV retrovirus would destroy T4 immune cells responsible for intracellular immunity resistance. The lack of immunity cell monitoring would mean that tumor cell clones that form in every organism by incidental mutation would no longer be held in check and could increase at will. Hence Kaposi's cancer would develop without substance-induced immunosuppressive agents. Thus a call was made at the First International Congress on AIDS in 1983 to carry out a series of human experiments to test this cancer theory. Meanwhile, after use of another immunosuppressive agent for organ transplant patients, cyclosporin A, not only Kaposi cancer tumors but lymph cell cancer too developed in the brain, along with solid carcinomas in a variety of organs. Rahm and Zeit, your book documents the substances with which these planned experiments were or still are being carried out with AIDS patients and HIV positives. What were the results? Kremer, all AIDS patients were treated with the immunotoxic chemoantibiotic cotrimoxazole of all things and related substances such as long-term prophylactics against the lung fungus infection PCP. From 1987 on azidothymidine, AZT, was also used against HIV, supplemented from 1989 on by AZT medication for HIV positives without symptoms. During the 1990s a complete battery of AZT-related substances plus other preparations toxic to mitochondria were prescribed as cocktail or combined therapy. Sooner or later these substances logically produced AIDS and cancer among the patients. Naturally, none of those affected would have taken part in these medical experiments if they had been informed that the goal was to disable the cellular immune defense medically in order to test the immunity monitoring cancer theory. The manipulated fear of death from the fatal HIV infection made the patients and parents of newborns and children with HIV-positive test results willing to cooperate in taking unlimited AZT, cotrimoxazole, etc. Rahm and Zeit, you are the first researcher who explained the real action mechanism of AZT and cotrimoxazole based on results of international research on nitric oxide, NO. And you drew the conclusion from published clinical studies with these substances that long-term medication with AZT and cotrimoxazole is a dangerous bodily harm with fatal consequences. Kremer, AZT has the identical nitrogen action profile as azathioprine. The azido group in AZT blocks cell respiration in the mitochondria just as the aza group does in azathioprine and the analogous action group in thimetoprim. The inevitable results are with very high probability AIDS, cancer, as well as nerve and muscle cell degeneration, as hundreds of clinical studies on HIV/AIDS medicine have proved beyond doubt. The published evidence is overwhelming. Rahm and Zeit, have AIDS and cancer virus researchers been able to prove the immune surveillance theory of cancer causation with their perverse experiments on human beings? Kremer, no, since they were fixated on mutations in the DNA nucleus and viewed cancer cells as foreign bodies, they were investigating the wrong scene of the crime. Nor have they solved the so-called AIDS puzzle. What they could not foresee was the fact that fundamental findings outside orthodox AIDS cancer medicine were gained from the end of the 1980s, and these have guided virus researchers' theories misled. Rahm and Zeit, Can you brief us on the results' most important findings? Kremer, all human cells are the genotype of an primeval single-celled organism settlement about 1.5 to 2 billion years ago, with energy preparation not reliant on oxygen but by acquisition of energy through oxidation. The latter, called mitochondria, continue to live as cell colonies in all cells of algae, plants, fungi, animals, and human beings. Genotypes of both single-cell organisms were integrated into a nucleus. The mitochondria conserved a residual genotype for independent protein synthesis in cooperation with protein encoded within the nucleus imported into the mitochondria. The more than 1,300 mitochondria existing on average in all human cells possess collectively about 50,000 active genes, a greater number than in the nucleus. Between the mitochondria colonies, that represent 90% of the total energy in the cell's latent and active phases, and the host cells, there is also a complex import-export system operating through mitochondrial gates for protons and electron flow, ionic exchange, preparation of the universal energy carrier molecule ADP, and various metabolic products. Since ADP cannot be stored, the mitochondria, amounting to more than 1,000 times the number of our body cells, produce an unbelievable amount of ADP daily. It equals roughly the magnitude of our body weight. The mitochondrial gates, and this is the new finding, are controlled by a mixture of gases consisting of nitric oxide, NO, and peroxide anions. The latter accumulate as a product of the oxidative respiration chain in the mitochondria. NO gas was verified during the mid-1980s as a basic functional gas found in almost all human cells. There is a gas-controlled alternating rhythm in the form of energy preparation between the mitochondria colony and the cells as a whole. During the late cell division phase, the early wound healing phase, and the embryonic phase, up to the moment of birth, preparation of potential energy is overwhelmingly shifted to production of non-oxidizing and fermenting ADP. This protects the genome portions of disorganized host cells that during the cell division are more sensitive to oxides and their derivatives than the mitochondrial genome portions. Depending on redox activity, this primordial genome portions express the necessary enzyme protein for alternative switching of oxidizing to non-oxidizing energy preparation. Thus our primeval cell symbiosis possesses a genotype duplicate and a duplicated energy preparation system. We are biological hermaphrodites in the evolutionary sense of life. All bioenergy and biochemical processes, above all naturally those in the mitochondria too, depend on a varyingly intensive negative redox potential as a biophysical prerequisite for complex proton and electron flow. This is guaranteed chiefly by glutathione, a tripeptide unique to quantum physics, that avails its central molecule, the amino acid cysteine, via the hydrogen sulfide group especially freely convertible protons for all detoxification services. Rahman Zeit, what are the consequences of these findings in understanding the causation of cancer, the causes of AIDS, and therapy for cancer and AIDS? Kremer, the consequences are fundamental. In the case of cancer and HIV positive, that means increased production of many specific antibodies. In full-blown AIDS, that is, intracellular fungus, protozoa, and mycobacteria infections as well as a few really existing virus infections, it means ulcerative colitis, severe traumas, burns, and other systemic and chronic diseases. We have a systemic lack of cysteine and glutathione as the result of excessive cysteine and glutathione use, as with the nitro compounds above, and/or lack of cysteine uptake and/or disturbance of new cysteine synthesis from methionine in the liver, for example, through folic acid inhibitors such as cotrimoxazole, and/or disturbance of new glutathione synthesis, toxic and pharmatoxic due to a variety of substances. The organism suffers from a striking lack of freely convertible protons. Under current civilization conditions, the organism must cope with more than 60,000 poisons in the glutathione system. Transformation to cancer cells can develop through a shortage of glutathione when the mitochondrial respiration chain's reserve capacity for ADP production is reduced insidiously below a critical level of reserve energy, apparent lack of oxygen, pseudohypoxia. The primordial genome portions in the nucleus genotype function in this case as a proton shortage memory. In genetic and supergenetic terms, it develops into highly complex counter-regulation. Alternating switching with the mitochondria is blocked. The cells can no longer switch back after cell division and remain caught in the division cycle. Nor are cancer cells transformed in this way any longer able to die a programmed cellular death, because the mitochondrial gates that would need to open remain closed due to intense counter-regulated no-gas synthesis. Crucial here too is the circulatory calcium exchange formed between the mitochondria and the cell plasma that is also handicapped. Cancer cells have a striking embryonic character in many respects. Thus it involves a surviving reswitching mechanism on the disorganized gene and energy program, a regression that could not be explained in the past by malignant coincidental mutation. From an evolutionary medicine standpoint concerning the cell symbiosis processes, one can comprehend cancer cell transformation if one understands the laws of coevolution. Raman Zeit, can the blockage of defective alternating switches for cancer cells be reversed? Kremer, that is the cardinal question for therapy. The disappearance of Kaposi sarcoma after eliminating azathioprine, that caused high use of glutathione as well as all nitro compounds, suggests this. Yet in the meantime we have an abundance of other evidence. It was also possible in animal experiments to prompt tumor cells as well as metastases to disappear completely by stimulating synthesis of no gas. Undoubtedly the most impressive is the success in healing cancer by balanced high dosages of cysteine and glutathione to regulate the potential for redox by means of preparations with good bioavailability. Raman Zeit, does glutathione therapy suffice? Or must other measures be combined with it? Kremer, cell symbiosis therapy to harmonize redox with equal amounts of cysteine and glutathione is a must as basic therapy. Yet cancer is a highly individualized and highly complex event. Countless studies during the last 10 years have proved the effectiveness of various therapeutic options in counter-regulating cancerous cells by non-aggressive inhibition. The art of healing through counter-regulated cancer cells calls for carefully thought-out interplay between gas pedal and brake, so to speak. Since basic understanding of cell symbiosis programmed by evolutionary biology was not yet sufficiently advanced, past cancer therapy lacked broad-based testing of a systematically combined and rationally assured overall concept of biological compensation therapy or, expressed in traditional terms, harmonizing of the yin and yang. In the meantime, however, we did understand why cancer patients died mainly from cachexia's tuberculosis syndrome as the result of a nitrogen and energy imbalance. If you ask cancer specialists how to stop their cancer patients' cachexia, even today you will hear by supplying high-calorie protein. A study in German clinics found half of the cancer patients to be undernourished. As one can verify in the standard works of AIDS medical officialdom, therapists treating AIDS as well as cancer have for decades confused cachexia, called HIV-related wasting syndrome in the case of AIDS patients, with the chronic state of hunger. They have not understood why the protein was mainly excreted as urea. On one hand, cachexia results from a proton deficit due to lack of cysteine in the liver that leads simultaneously to a lack of glutamine and arginine as well as to an increase of glutamate in the plasma. On the other hand, recycling in the liver produces the glycolysis product lactate. This occurs due to a 20 times higher glycolysis decomposition by fermentation in the cancer cells, an excessive use of protons, and higher investment in energy than was obtained originally as energy from fermentation of glucose. These feedback processes are regulated via type II cytokines, communication protein that are synthesized by force due to the glutathione shortage and prevent in the net result protons from splitting out of the cysteine. Thus the primordial anaerobic principle of low fluid proton fixation also shows up with cachexia in comparison to the high fluid proton floating of intact cell symbioses. Check the laboratory findings notes of clinics and medical practices. Then it will be clear to you why the causes of systemic amino acids dysregulation are usually misunderstood and inadequately balanced. Raman Zeit, can biological compensation therapy dispense with chemotherapy? Kremer, in principle, yes. Chemotherapy seeks above all to inactivate the cell division process. Yet it affects the mitochondrial structures primarily. As descendants of eukaryotic bacteria, they possess no protective proteins and no effective repair mechanisms for their genes. However, they are many times more sensitive to peroxide chemotherapy as, for example, genes in the nucleus that are especially protected. During the long course of evolution, the mitochondria have functioned very well. Among animals living wild, DNA defects in mitochondria have been detected rarely, while the list of congenital and acquired mitochondrial illnesses among human beings from Alzheimer's to Parkinsonism and severe heart myopathy becomes ever longer. The problem of any chemotherapy is that cells in any tumor are found with variously intensive degrees of counter-regulation. Thus one can use chemotherapy to kill part of the cancer cells. That's called remission. Other cancer cells must encounter intensified counter-regulation. This is due precisely to the intentional simultaneous attack on the mitochondria. It also applies to cells that are not yet transformed and still exist in the compensated state of cell dyssymbiosis. As a result, metastatic cells, or secondary tumors, can be selected. Cancer patients who have been subjected to biological compensation therapy before and during chemotherapy report less side effects and better tolerance to chemotherapy. Yet the problem is the later consequences of chemotherapy. Once damaged, mitochondrial DNA is no longer reparable. Defects can build up over the course of years. This cannot be calculated on an individual basis. Based on a long-term study in the German Cancer Center, the average survival period for cancer patients after chemotherapy amounts to 3.5 years, without chemotherapy 12 years. The finding dates back more than a decade, but not much has improved in the meantime in regard to survival odds with most solid carcinomas. In the USA, the war against cancer declared in 1971 was considered lost in 1996. Rahman Zeit, what is your advice for those affected? Kremer, for those affected and their family members as well as those not yet affected, since every third human being will be diagnosed with cancer during the course of his life, the only advice is not to be driven into panic by the shock of diagnosis. Rather adapt to the basic knowledge about why cancer cells are not foreign bodies but reactions programmed by the evolutionary biology of our cell symbioses that can be reversed in principle if one consistently gives the body what it really needs. Obviously, at the end of the day, the informed patient can only decide in cooperation with enlightened therapists if he has the necessary mental support. Rahman Zeit will surely publish addresses of individual therapists, counseling organizations, patient initiatives, and internet addresses that already have experiences with biological compensation therapy. Related seminars for those affected and therapists are also offered at the Wolfrat-Schauser Academy. In view of the more than 100 different forms of cancer, there are too many special questions that one can only discuss in individual counseling or in therapy seminars. Rahman Zeit, what are the consequences for the causes, diagnosis, and therapy in case of HIV/AIDS? Kremer, the crucial thing is the knowledge that the T4 helper immune cells in the blood are not destroyed by some sort of virus, neither by HIV nor by another virus, and that the cellular immunity is capable of recovery. Since the outset of the 1990s, it has been proven in human beings that there are two subgroups of T4 cells, as with all mammals. These are not differentiated in laboratory measurements by HIV/AIDS researchers. Yet the T4 cells count in the bloodstream is determined by the relationship of these two subgroups called Th1 and Th2. Dominant Th2 cells are formed by lack of cysteine and glutathione. They have migrated from the bloodstream and stimulate antibody production in the lymph organs. The number of these T4 cells in the bloodstream declines automatically. This produces cytotoxic no-defense gas as Th1 cells against cells that contain pathogens internally. This switch in the T4 cell balance, as in the case of cancer cell transformation, is regulated by type 2 cytokine. If it is lasting, it causes the disposition for AIDS. As has been proved, the really endangered among the HIV positives have type 2 cytokine dominance. This also applies for the dual strategy of immune defense in the cell's interior and in their outer environs. The same programmed evolutionary biology laws of counter-regulation prevail when lacking freely convertible protons as they do with cancer. Since most therapists do not seem aware of these laws or do not want to know about them, sooner or later they unintentionally kill those stigmatized as HIV positive, even those not even primarily endangered by AIDS. This occurs because they measure neither the cysteine and glutathione levels nor other important laboratory parameters. Instead, they prescribe unlimited glutathione-consuming chemotherapy and chemoantibiotics toxic to mitochondria. Or if they do make measurements, the HIV fixation prompts them to carry out chemo treatment anyway. A minority resorts to a lazy compromise, treating simultaneously with a half-hearted supplemental therapy using L-cysteine or reduced glutathione. But in the long run, this cannot compensate for the counterproductive toxic effect of the chemo substances. Rahman Zeit, but what happens in the organism of the HIV positives who feel better subjectively after beginning the cocktail therapy? Kremer, this is the so-called lawnmower effect. The most frequent opportunistic pathogens, fungi, and protozoa also possess mitochondria whose respiration chain is inhibited by AZT and cotrimoxazole. But this effect should not be confused with the fictitious HIV inhibition. The crucial point is that individual fungi and protozoa can survive the chemotherapeutic target attack just as individual cancer cells can survive by counter-regulation. That is the so-called resistance problem. The real basic evil is that the lack of glutathione and the reduced production of no defense gas dependent on it are not in balance. Thus the body refuses the surviving means of self-help. Instead, the deficient state resulting from the chemotherapy intensifies, and counter-regulated resistant parasites and cancer cells are bred. The detoxifying role of the mitochondria in the immune and non-immune cells is forcefully weakened even more until reaching the point of critical stress. Hence, extending survival of the so-called inevitably fatal infection really reflects an error in therapeutic approach that maintains the conditions of the vicious clinical circle. Several clinical course studies in the USA in the meantime have confirmed that precisely those patients die whose alleged viral load measured by the extremely dubious PCR method in this case was lowered by combined therapy. This was seemingly confirmed by the relative increase in T4 cells within the blood serum. The relative increase in T4 cells is based on the reverse current of Th2 cells that can no longer carry out their helper function for cells producing antibodies, since their maturity is blocked by chemotherapy. The alleged decrease in HIV RNA is the result of increased RNA consumption from the serum for DNA repair by genes made defective by the chemo treatment. Therefore, viewed over the long term, these are therapeutic pseudo-successes that deceive both patients and therapists about the favorable effects of chemotherapy and chemoantibiotics. Without consistent compensation therapy, it is merely a question of the patient's disposition how long it takes before the point of no return is reached as a result of long-term chemotherapeutic poisoning of respiration in the immune and non-immune cells. But the time fuse effects should also be taken very seriously among HIV-positive patients who have taken long-term AZT and cotrimoxazole, for instance, then distance themselves from it at the critical point, live healthily a few years, and suddenly develop fatal organ failure, heart attack, ventricle failure, sepsis, brain or liver coma, etc. These events have nothing to do with HIV, even if HIV/AIDS physicians suggest it. Rather, they concern late vascular symptoms of chemotherapy, irreparable mitochondrial DNA defects resulting from absolutely contraindicated anti-HIV medication and long-term anti-AIDS prophylaxis. Several orthodox HIV/AIDS research groups in the USA have published that the proven damage to mitochondrial DNA after combined therapy resemble intense inborn mitochondrial DNA damage. We have known for a long time that this damage can accumulate and build up after continued division of the mitochondria and added stress, that cell respiration fails, and that fatal organ failures can appear in tissues and organs with abundant mitochondria or, in case of cellular counter-regulation, cancer transformation. It is crucial that those affected be told how one must check this danger and can compensate for it with biological non-toxic means. This applies regardless of whether primary risks have led to the HIV-positive test effect. However, those affected are particularly hepatitis patients, whereby the hepatitis C diagnosis is just as false as HIV, but an autoimmune hepatitis can emerge. Here too many special questions can arise that can only be answered individually or in therapy seminars. In my experience, it is mainly those affected with blood groups B, A, Anib who show an increased disposition for deficiencies of freely convertible protons and are endangered by systemic diseases. Since about 50% of the population has blood group O, this fact is one of many that explains the varying disposition to disease at the same or even higher exposure to risks. The association for increased disposition among human beings with certain blood groups, B, AB, and A, for certain forms of cancer, asthma, etc., polymorphism enzyme, is known, but very little systematic research has occurred on it. This also applies for the suspicion of later after-effect symptoms after mass vaccinations that can apparently trigger an increased disposition for Th1-Th2 switch, particularly among vaccination subjects with blood groups B, A, and AB. During pregnancy, there is a type 2 cytokine status in the placenta, and after birth a natural Th1, type 1 cytokine, Th2, type 2 cytokine, balance must be trained in the most natural way possible. Indeed, those affected have strikingly few bacterial infections in childhood. This is due to induced elevation of the Th2 status. It results from vaccinating against unwanted programming at a lowered sensitivity threshold for the Th1-Th2 immune cell switch and the cytokine type 1 type 2 switch in the sensitive formative phase during early childhood. The advantage is improved antibody production. The disadvantage is reduced no defense gas synthesis, increased preparedness to react against foreign protein and toxic substances, and increased consumption of glutathione. But asthma, neurodermatitis, allergies, cancer, etc. can probably develop with greater frequency later. The striking thing is that AIDS patients stigmatized as HIV positive have almost all been born after World War II, i.e., in an era when the human immune system had to cope for the first time with antibiotics and vaccines. Indeed, a HIV infection supposedly communicable to anybody would hardly have spared older patients. This also addresses the chemoantibiotics thesis that one first recognized as clinically relevant, the most frequent AIDS indicator illness, lung infections with the airborne pneumocystis fungus, PCP. This occurred at the end of the 1930s as prematurely born babies were treated against bacterial sepsis with the newly developed sulfonamide drugs and developed PCP instead of bacterial infections. Sulfonamide, developed from azodiestuffs, inhibits folic acid synthesis in bacteria and in human mitochondria, consuming extreme amounts of cysteine and glutathione. The lung's mucous membrane requires a roughly 100 times higher cysteine and glutathione level than in plasma. Prematurely born babies died 60 years ago of pneumocystose, PCP, after sulfonamide therapy for white lungs. Long-term medication with the trimethoprim/sulfonamide preparation cotrimoxazole and other folic acid inhibitors has occurred in exactly the same way since the 1970s. It has become the joint determining cause of disease and death for by far the most frequent AIDS indicator disease, PCP, and other fungus infections dominating in the AIDS disease catalog. After a series of fatalities following cotrimoxazole treatment of non-HIV positives registered during the 1985 to 1995 period, the responsible officials in England and the USA sharply restricted the indication recommendation for cotrimoxazole to a half-dozen rare infections for a treatment duration of 7 days or a maximum of 10 days. Absurdly, one must even say criminally unrestricted cotrimoxazole treatment of already immune-deficient HIV positives and AIDS patients was the only exception to this new restriction. In Germany there are still absolutely no restrictions on cotrimoxazole. Rahman Zeit, clinical HIV/AIDS researchers have contended for a few years that a protease inhibitor plus drugs such as AZT and one like nevirapine introduced since 1996 had brought about a therapeutic breakthrough in treating HIV/AIDS and speak of eliminating HIV in 3 to 4 years. The media suggests the so-called Lazarus effect by medication with AZT plus nevirapine plus protease inhibitors. Kremer, the campaign for Krix-Evon, Viramune, etc. was initiated in 1996 by the multinational public relations firm Burson Marsteller, advertising partner for mega-pharmaceutical concerns such as GlaxoSmithKline, Pfizer, Eli Lilly, and Bristol Myers Squibb. All healing claims have had to be retracted since 1999. The consequences of a medication like nevirapine plus AZT and protease inhibitors such as Krixivon were too obvious this time to be able to project this to HIV. Drugs like Krixivon had caused failure of the liver, pancreas, and kidneys, diabetes, massive lipometabolic disturbances, high blood pressure, heart attacks, strokes, etc. According to clinical studies, it clearly involved the approach of orthodox HIV research groups to pharmacotoxically induced mitochondrial diseases. Fatalities by liver failure after medication with drugs like Krixivon are not counted as AIDS fatalities, since they often appear before development of the official 29 AIDS indicator diseases, even among patients previously without symptoms. Since then it has been publicized that HIV requires a medical elimination period of 10 to 60 years. But regrettably the tolerance of combination therapy, for instance, AZT plus nevirapine plus protease inhibitors, is limited to a maximum of 2 to 3 years. The collective virus obsession enables HIV/AIDS medicine to operate in a lawless sphere without responsibility for the often fatal consequences. Yet ignorance and unwillingness to know can no longer be an alibi for the humiliating helplessness and indifference among officials, professional medical associations, and almost all fellow human beings who face this almost unprecedented lack of scientific and medical ethics. It's worth noting that journalists from Der Spiegel have been making passing comments about AIDS for almost 20 years, and despite better information on the latest prognosis of unscrupulous propagandists for HIV, AZT, etc. In the next 10 years the survivors of combination therapy are increasingly likely to develop cancer and heart attacks as consequences. What Der Spiegel does not report is this: in all studies on HIV positives who remain free of symptoms longer than 10 years, it has been determined that these affected are being termed long-term survivors, or, more to the point, as long-term objectors who never, or among a low number only for a very short term, were treated with drugs such as AZT, cotrimoxazole, or protease inhibitors. Rahman Zeit, how do you think your colleagues will react to publication of your book? Kremer, I think it will be overwhelmingly positive, since the immediate value of the new findings is obvious for survival of the patients affected. I see my role as a mediator independent of the pharmaceutical industry with assured basic knowledge of diagnostic and therapeutic practice. Evolutionary medicine's plausible explanation for the causes, diagnostics, prevention, and therapy concerning AIDS, cancer, and degeneration of nerves and muscle cells among other maladies can no longer be argued away by yesterday's theories. There is an urgent need for anxiety-free enlightenment among those affected and for rational continuing education available to open-minded therapists. After many years of my own medical experience, I think that knowledge of the elementary laws of cell biology, goal-oriented laboratory diagnostics, and differentiated treatment of biological compensation therapy should be indispensable, fundamental, and helpful for any therapeutic approach rooted in natural science in waging the 30-year war against cancer and pursuing the 20-year hunt for the virus. This interview was translated from German.